audience now after about a year of working at Rush, and I'm really happy to be here today. And I'm going to be giving just a brief overview of Parkinson's disease before you guys get to all the fun lectures. So this is probably going to sound very familiar to some of you, but hopefully it will be helpful in reiterating the information that you already know about Parkinson's. So from a big picture perspective, for some of you who are new to the Parkinson's disease and movement disorders clinic, I just want to introduce you to what movement disorders are and why we as neurologists are called movement disorder specialists. And so movement disorders are characterized by abnormalities in, I'm sorry, I haven't changed the slide. Where is, okay. Here we go. Movement disorders are characterized by abnormalities in voluntary movements or the presence of involuntary movements. And for the most part, these arise from inherited or sporadic diseases of the nervous system, in fact. And for the most part, they arise from structures deep in the brain. And that's why we as neurologists are called movement disorder specialists. And our main focus is diseases of voluntary and involuntary movements. And so here's a brief outline of what I'll cover today. So we'll briefly go over how to make the diagnosis of Parkinson's, who gets Parkinson's and when, what happens in the brain, the disease stages, and we'll kind of review some common non-motor symptoms of Parkinson's. And I'll end with a small focus on falls and falls prevention. And so just a little history on Parkinson's disease. So Parkinson's was first described by this British surgeon named James Parkinson. You've probably heard this a million times, in an essay on the shaking palsy. And he wrote this based on his observations of several patients that he observed in the streets of London having a similar syndrome that he labeled the shaking palsy. And many of these patients he described as having tremulous motion, bent forward at the trunk, and having a propensity of walking from passing from a walking to a running pace, and the senses and intellects were spared. And so thereafter, by the 1860s, a very well-known French neurologist and anatomist, Jean-Martin Charcot, characterized the cardinal feature of Parkinson's, which is bradykinesia. And bradykinesia means slowness of voluntary movements. And then nearly a century later, we were able to do enough research to really figure out what is the neurochemical basis of Parkinson's disease, and that is a dopamine deficiency. And so what is Parkinsonism? And so Parkinsonism falls into this category of hypokinetic movement disorders. That means too little movement. And that's compared to hyperkinetic movement disorders, which means too much movement. Under hyperkinetic, one of the more common movement disorders is essential tremor. But Parkinson's is on the other realm. It's hypokinetic. And so the most common cause of Parkinsonism, which is a clinical syndrome, is Parkinson's disease. And then rarer forms of Parkinsonism include things like Lewy body dementia, multiple systems atrophy, progressive supranuclear palsy, and cortical basilar degeneration. So you might hear us talking a lot about Parkinsonism at your appointments, and you're wondering what does this actually mean? And so it means it's a clinical syndrome of certain features that we see on your exam, but 90% of the time, 80-90% of the time, Parkinsonism is due to Parkinson's disease, and then there's these atypical forms. And so these are the clinical features of motor features of Parkinson's that helps us make the diagnosis of the condition. So in order to have Parkinson's disease, you have to have bradykinesia, which is, again, that slow, decrementing voluntary movements. That is the cardinal feature of Parkinson's disease. And then you have to have at least one of these three features: rigidity or muscle stiffness, tremor, which usually is a rest tremor and often starts asymmetrically on one side, and then postural instability, which really manifests as imbalance and fall risk. And so these are two acronyms that might help you remember all of these features of Parkinson's. So this is how we diagnose Parkinson's disease. And so in addition to us figuring out whether our patient has meets those criteria that we just went over, we also ask a lot about these supportive criteria for the diagnosis, these little clues in your history that helps tell us whether you have Parkinson's disease, idiopathic Parkinson's disease. And some of these include symptoms beginning asymmetrically, just on one side of the body, a progressive course, so things slowly getting worse, this very characteristic rest tremor that Parkinson's patients may have, having a good response in terms of symptom control to levodopa, because like I mentioned, all Parkinson's disease is due to a levodopa deficiency. Having gait problems that include things like freezing and shuffling, having a stooped posture, having a quiet or rushed voice, which we call hypophonia, and then having things like masked faces or decreased facial expression, and even something as small as having a progressively small handwriting over time. These are all kind of clues that maybe a patient has Parkinson's disease. And so who gets Parkinson's? And so right now, Parkinson's is actually considered the second most common neurodegenerative disease after Alzheimer's disease, and that's primarily because of our aging population. And so about 1 to 2% of people over the age of 65 are diagnosed with Parkinson's, and 3 to 5% of people over the age of 85. So as you can see, the biggest risk factor for Parkinson's disease is increasing age. And right now, there's about 1 to 2 million people in the U.S. and Europe with a diagnosis of Parkinson's. And it does tend to be a little bit more male predominant, so more common in males with a ratio of 1.5 to 1. And these are, you'll see at the bottom, some prevalence and incidence numbers for the state of Illinois. And so when does Parkinson's occur? Like I said, the most common risk factor is advancing age. So the average age of Parkinson's is actually 65, and it's very rare to have Parkinson's before the age of 50. And so when we see patients who are young onset, who present at the age of 40 or below, we categorize these patients as early onset PD, and we think about genetics possibly being involved. Please remember that most Parkinson's disease, which we call idiopathic Parkinson's disease, is not genetic in origin as far as we know right now. But these young onset patients, we always have to think about their genetics. And so about 10% of Parkinson's disease has been found to be genetic. And we have about 17% chance of finding a known mutation that is causative. And here are some of the common mutations that many researchers are studying: Parkin, PINK1, LRRK2, and GBA. And so we only really consider genetic testing if you have a known mutation that runs in your family, if you present at a very young age, about less than 40, and if there's a specific ancestry that might be suggestive of one of these mutations. And so most Parkinson's is what's called, again, idiopathic Parkinson's disease. And what we mean by that is that we don't know the cause quite yet. And again, this is 90% of the cases of Parkinson's, and the other 10% could be genetic, okay? So likely we think that the cause of idiopathic Parkinson's disease is some combination of genetics and environment, a genetic predisposition towards Parkinson's, and then an environmental factor or several environmental factors kind of pushing you over to developing the disease. And we know that because of a lot of studies that people have done on environmental exposures that are linked to Parkinson's, for instance, Agent Orange in the Vietnam veterans, and various other pesticides, herbicides, and then also solvents like degreasers, historical dry cleaning solvents. These have all been kind of linked to Parkinson's, and also head trauma, repetitive head trauma, for instance, in someone like Muhammad Ali. And so the common feature in all idiopathic Parkinson's disease is this dopamine deficiency. And so where does this come from? So it's essentially results from an abnormal accumulation of this protein called alpha-synuclein. And so this abnormal accumulation results in Lewy body formation in the brain cells or the neurons. And that's why you might hear some of us calling Parkinson's disease a synucleinopathy or a Lewy body disease. That's where those words come from. And so ultimately, there's a loss of those neurons that produce dopamine in this area in the brainstem called the substantia nigra that you see pictured here. And dopamine is extremely important in the brain, in those deep structures in the brain, for movement. And so the motor symptoms of Parkinson's begin when about 50 to 60% of these dopamine-producing cells are lost in the brain. And here's just some other brain pathways can indeed be, dopamine is vital to other brain pathways as well, in addition to movement. So first and foremost, it's movement, but also dopamine is important for pathways that have to do with cognition, reward and motivation, as well as pleasure. And so these might come into play when we talk about non-motor features of Parkinson's. And so one other thing that I want to discuss briefly, just because there's been a lot of hype around this, is where does Parkinson's start? Where does this environmental exposure come in? And so people have postulated that Parkinson's may start in the gut. And the reason why we've postulated this is because, one, some of these non-motor features that are gut-related, like constipation, do tend to predate these motor symptoms of Parkinson's by about 10 to 20 years. And going and studying the guts of patients with Parkinson's, we've been able to see that aggregation, the accumulation of that bad protein and the Lewy bodies in the nerves of the walls of the gut. And so we're thinking potentially that this abnormal accumulation is kind of stemming from the gut after ingestion or exposure to an environmental toxin, and then it's traveling upward, almost like a virus, through those nerves up towards the brain, and then thereafter, 10, 20 years after, you may start experiencing the motor features of Parkinson's. And so this is kind of where all of that talk is coming from. And so we talked about the motor features of Parkinson's with the two acronyms, TRAP and SMART. And so here's a list of all of the non-motor features of Parkinson's that aren't recognized enough, I think. So one of the big ones is REM behavior disorder, like vivid dreaming or dream reenactment, which is very common in Parkinson's disease, and it often predates, again, the onset of the motor features about 10 to 20 years. Fatigue, depression, we talked about the quieter voice. Constipation, autonomic dysfunction is a huge non-motor feature of Parkinson's, and that includes something called orthostatic hypotension, which is low blood pressures when you stand up too fast. That also as part of autonomic dysfunction, and you can kind of think of this as the automatic things that need to go right in your body. Sexual dysfunction falls into that category. Drooling, hallucination, psychosis, and also cognitive changes. These are all in the category of non-motor symptoms of Parkinson's. And this is a nice little picture that kind of shows you, kind of summarizes all the things that we just discussed. It's at 50 to 60% dopamine neuron loss that you start to see the more tangible motor features of Parkinson's disease. And so it's before then that it's potentially you are seeing the non-motor features like the constipation, the REM behavior disorder. But keep in mind, always keep in mind, and I wrote this disclaimer, that every patient with Parkinson's is different. And so this is kind of why we know that Parkinson's may be caused by different things or different combinations of things, because not all of you are going to have all of this, and not all of you are going to develop all of this. So please keep that in mind. And so here's just another schematic of how we approach Parkinson's disease and medication management. So at 60% of dopamine loss, you start to experience the motor symptoms of Parkinson's. And prior to that, perhaps the non-motor symptoms of Parkinson's. And what we do in terms of medication is that we want to kind of change the trajectory of this and supplement the dopamine, right, in order to help improve your symptoms of Parkinson's. The medication is purely symptomatic management, so it's not changing the course of the disease in any way, in the sense that we're not changing the underlying neurodegeneration, but we're helping you symptomatically, so we're kind of changing the slope a little bit. And so we're hoping to improve the symptoms that you're experiencing, but remember that neurodegenerative condition, the neurodegeneration continues, and we're not able to halt that, unfortunately, at this time with any sort of medication. And so that's why you see movement disorder doctors, so that we can kind of keep up with the changes and adjust your medication with time. And so here are the kind of general overview of the disease stages in Parkinson's. So there's mild, moderate, and advanced. And these are the medications and modalities that we use to treat these stages, just in general terms. So in mild disease, we use what we call levodopa-sparing agents, so MAO inhibitors like Azilect, and then also dopamine agonists like ropinirole and Mirapex. When we move on to moderate stage disease, we start to use our mainstay of treatment. The closest thing we get to a dopamine supplement, which is levodopa. And we can use the other medications kind of to smooth things out. And then finally, in more advanced disease, when things like dyskinesias come into play, or lots of motor fluctuations where the meds are really unpredictable, we resort to more advanced and invasive therapies such as intraintestinal infusions like Duopa and, of course, deep brain stimulation. And so, as you saw across the board, exercise is reinforced at every stage of the disease. And that's because we know that from some research studies that exercise is the only thing that's potentially neuroprotective and could potentially modify and slow down the progression of Parkinson's disease. So that's why we're big proponents of exercise, and I know Dr. Fleischer will talk about this a little bit more. I'll just skip over this just for the sake of time. And I wanted to talk just a little bit more about these non-motor features of Parkinson's that I think are important. One of them is speech changes in Parkinson's. And so in terms of speech changes in Parkinson's, the biggest component of this is low volume or hypophonia. Patients can have monotonous speech, hesitations, and short rushes of speech, and often they describe this as stuttering. And so there are kind of non-invasive ways to help with these speech changes. And one of the biggest ways to exercise kind of your speech and your volume is doing a therapy called the Lee Silverman voice treatment therapy. And just practicing speaking out loud and shouting almost. And one other thing that often comes up in our patients is various nonverbal communication that can be affected in Parkinson's. And so the reduced facial expression in Parkinson's patients is often misinterpreted by people. So PD patients are described as being passive, uninterested, maybe even sad. And so we really, as caregivers, we really have to recognize that this is part of the condition and be very patient and understanding of this. And so one way to approach this is, first off, recognizing that this is part of the condition. Essentially, there's slowness in the muscles of facial expression, and really taking the time and effort to look at your Parkinson's loved one, and when you're speaking, reduce distractions when speaking to them, eliminate background noise, use shorter sentences, and really minimize non-literal language. Because there have been some research studies that have shown that Parkinson's patients even have trouble interpreting other people's facial expressions and emotion recognition. And then constipation is a huge issue, and I think Dr. Wittig might be talking about this next, but this is a huge quality of life issue that often falls to the back burner at our visits, but we have so many different ways that we can kind of attack this issue. And so please keep in mind that this is something that we want to discuss with you at our visits, and we have lots of remedies for this that we can utilize. And then just briefly, sleep dysfunction in PD can there's several levels of dysfunction in terms of sleep in PD. We talked briefly about REM behavior disorder and dream reenactment, but sleep can be affected in a lot of different ways in Parkinson's. Sleep can be extremely fragmented in general. Patients might have restless leg symptoms that are keeping them up, or just general stiffness in bed. All of this can lead to excessive daytime sleepiness and can throw off the sleep at night. And even sleep attacks can occur in response to certain medications that we're prescribing. And so we do have remedies for this as well, and I've listed some of them here. So it's really important to talk to your doctor about this stuff, because poor sleep can really worsen everything, or whether it be motor or non-motor features of PD. And so I wanted to kind of briefly touch on falls, as I as alluded to in the title of my presentation. So falls in PD, this is my own kind of research interest, and I'm interested in gait in general. So falls in PD can be very multifactorial. So they can be due to bradykinesia, which manifests usually as that shuffling gait. They can be due to postural instability, where you're falling backwards or even have difficulty getting up out of the chair, especially low chairs. And then finally, they can be due to what's called freezing of gait, which patients often describe as, my feet feel glued to the floor and I get stuck. And so freezing of gait actually can manifest in a lot of different ways. It can just be an initial start hesitation when you first get up and your foot gets stuck. It can even be a complete halt in movement when you're walking. There can be stuttering or kind of trembling steps, even in just one leg. And this usually happens during turning, cramped spaces, even as you're just approaching a doorway. Freezing can also occur during sidestepping, and so when you're at the kitchen sink or when you're cooking, freezing can come out then as well. And it can happen in the off state, the on state, it can happen at all times, and so it's very complicated. And so some of the exacerbating features to falls and freezing include anxiety. So when someone freezes, they tend to start staring at their foot, and the anxiety builds up, and they can't kind of get over it. And so that's something that needs to be attacked right on. Divided attention or multitasking can really lead to falls. So even just, using your phone or carrying too many loads of groceries in both hands. An unsafe home, in terms of uneven ground and rugs, narrow areas, and lots of furniture and clutter, can really bring out fall risk. The wrong use of durable equipment like canes, which are very asymmetric. And one important thing is, if you have one fall, there's a lot of fear of falling that comes after that. And that fear of falling really leads to immobility and heightened anxiety, and as a result, you're at even higher risk of falling. And so how do we kind of attack fall risk and try and prevent falls? So first and foremost, physical therapy. The right type of physical therapy is most important, but we also want to smooth out people's dopamine regimens. We want to treat that anxiety that I talked about, and that might even require the use of an antidepressant. And we want to make sure people's attention and cognition are optimized too, and that might require a medication as well. And so the rest of it, which is the crux of treatment of falls and preventing falls, is non-invasive and it's therapy-based. And so here's just a list of things that one would focus on in physical therapy in terms of falls prevention. And if anyone is interested in falls prevention and is getting a little bit worried about their fall risk, I do have a research study that's going to be starting hopefully very soon, and you can, and it has to do with telephysical therapy or occupational therapy focused on falls prevention. If you're interested, you can email us at movingdisorder@rush. And so after the rest of the slides have to do with making the most of your visits, I'll have you guys take a look at that on your own, because we're running low on time. So thank thank you so much. I hope this was helpful.
I think what we'll do for the sake of time, we'll hold the applause for all of our wonderful speakers at the end, right before our break and after the panel discussion. I want to remind you that there are cards on your table. Please fill them out with any questions that you may have, and we will walk around and take them. The next speaker I would like to welcome is Natalie Weddick.
All right. Hi, thank you all for coming in today. I thought it might be appropriate to talk about diet and Parkinson's at noon, since I'm sure you're all very hungry, so I apologize for any of the increased appetite you experienced during this lecture. This is something that is important for everybody, given that everyone here eats. This is important for not just patients with Parkinson's, but also any loved ones. So I just wanted to get started and talk about diet and Parkinson's. So disclosures, currently doing a research project looking at immune biomarkers in the progression of Parkinson's and Parkinsonism, founded by Parkinson's Foundation and Baccalaureate Generous Gift. And then my training was funded by the Michael J. Fox Foundation. So as I mentioned, what you eat matters, and it's very important what you put into your body, because it can have effects on your symptoms if you have Parkinson's disease, but just in general in your overall health. So there are a lot of fads out there, and it's a little overwhelming. Which diet should we be following? Gluten-free, vegan, Whole30, Atkins, paleo, keto? Are you allowed to eat anything anymore? Yes, you can. And so just to talk briefly about the one that I would recommend, that would be the Mediterranean diet, and also the MIND diet, which is based off of the Mediterranean diet. And there's some reasons and actual studies that have supported this, in that having a diet high in monounsaturated fats such as olive oil, vegetables, fish, the omega-3, that this diet actually helps to prevent cardiovascular disease. And while your primary care doctor may warn you, you have to lose weight so you don't have a heart attack, they might not be telling you, you need to be healthy and eat right, because if you don't, you may develop dementia down the road, which I think is sometimes a little more pressing for people when they hear that information, because if you are not getting blood to your brain, then that is going to cause damage to your brain and can lead to symptoms that worsen Parkinsonism and also memory. And so the MIND diet has some nice simple recipes that are pretty easy to follow. And it basically is the Mediterranean diet plus other foods high in antioxidants such as berries. And it's summer right now, so blueberries, raspberries, it's a great season. I hope you can go and eat them guilt-free and think about you're helping to fight the progression of Parkinsonism, every blueberry, one blueberry at a time. I wanted to take the time to talk about protein in Parkinson's. It is important to get protein in your diet, as I mentioned, with fish, and then also even leafy greens have protein. But this is a little bit more of a hot topic for patients with Parkinson's, since our mainstay therapy is levodopa, and levodopa, it is inhibited, or the absorption of it is slightly inhibited with high protein meals. And so many people find that limiting the protein earlier in the day, such as at breakfast or lunch, may actually help their symptoms, since they absorb the medication of levodopa better. And we'll talk about this in further detail. So let's go back to what is levodopa. Levodopa is an amino acid. What's an amino acid? It's a precursor to protein. So levodopa is a very simple compound, came from the Mucuna purins bean and has been concentrated in high doses. And it's an amino acid very similar to tryptophan. So many people have heard about that, and they're reminded every Thanksgiving after they eat turkey and become a little tired. And so the amino acids in protein and levodopa are competing for the gateways into your body and into your brain. So if you have the protein and levodopa at the same exact time, there may be a little bit of, it may not absorb and feel the impact of levodopa as strongly as you would if you had eaten this medication with an empty stomach or maybe with some carbohydrates and non-protein foods. And so what foods have protein? I take this for granted. Many people know steak has a lot of protein and chicken and eggs, but also the things that I just mentioned that I want you to eat, like the nuts and the dark leafy greens, as well as milk and even avocado. So these things all have protein. And so let's talk about how to, if you are one of those patients who takes levodopa and may be sensitive to the impact of high-protein meals. And how do you know if you're one of those patients? Well, it tends to be patients who, after lunch, they may feel a slump. If they are eating cheeseburgers or something at lunch, they may feel like their symptoms worsen in the afternoon. And so a way to avoid this is to separate the protein. But if you're just starting taking levodopa, we recommend taking it with food, maybe some carbohydrates, because the side effect of levodopa is nausea. If you have been tolerating levodopa and you don't have any nausea with this medication, we recommend that you take your pills 30 minutes before eating. It's a nice way to remember to take your food or take your medications, and also a nice way to remember to eat. It is important to keep eating. And then, since the gut sometimes slows down for many people with Parkinson's disease, we recommend waiting 2 hours after. And so this is a soft recommendation. Many people seem to be having a heart attack coming in, but how do I time my meals with my medications? I'm taking my levodopa maybe sometimes every 3 hours, and I worry about their heart because I'm worried they might have a heart attack, trying to figure out the schedule. Nothing bad will necessarily happen to you if you take the levodopa with the protein. It is not dangerous. It's just that the medication will not be absorbed quite as well. So it is okay if you decide to have a spontaneous impromptu dinner and enjoy a steak, or maybe have a nice omelet with breakfast and you forgot to take your pills 30 minutes before your meal. It's okay to take them with your breakfast. I just wanted to further explain our reason for making these recommendations. And also, I don't want you to become so stressed trying to time the medication and food that you end up losing weight, because weight loss in Parkinson's is an issue. It's due to multiple factors: decreased appetite, medications cause nausea. For patients, there's increased muscle activity from the stiffness and sometimes tremor. While Parkinson's is often associated with weight loss, I still use if someone's losing weight is still, to me, a diagnosis of exclusion. And what I mean by that is I still want my patients to be having their routine cancer screenings, make sure everything else is fine, and that there's no other cause of weight loss besides attributing it first to the Parkinson's disease. The other reason why diet's important is because there are many symptoms in Parkinson's disease where your diet can actually help your symptoms. And many patients do not want to be taking so many pills, so it's beneficial to change your diet in ways to help your symptoms. Dr. Afshari talked about constipation. It is a debilitating and sometimes dangerous symptom of Parkinson's disease. I consider myself a failure if my patient goes to the ER with a bowel impaction that is preventable. The most common reason for worsening of constipation that my patients are not drinking enough water because it's hard to get up and go to the bathroom, and also there's urinary frequency, and so people are able to avoid going to the bathroom if they stop drinking water. So 6 glasses a day of water is what is recommended for patients with healthy hearts. Of course, if you're following with a cardiologist and you're on blood pressure medication, I would first clarify with your cardiologist how much water you should be taking in. And then the diet changes include whole grains, brown rice, leafy greens as well, fruits. It's a perfect time to be eating a lot of fruit, and then beans. The nice thing about fruit is that it can lead to hydration and without, sometimes patients will drink a full glass of water and then they know within 30 minutes they're going to be running to the bathroom. Eating melons and things high in water, it tends to be absorbed a little bit slower so that there isn't that urgency associated with the fruit. So this is a good way to try to promote hydration without sending people to the bathroom to urinate. Also, the medications are absorbed better with a full glass of water, so it's helpful to drink water every time you take your medications. For sleep, we want to avoid the sugar at nighttime. Alcohol may help you to fall asleep, but then the sleep is not as restful afterwards. So we want to avoid alcohol at night if possible, and then of course avoid caffeine later in the afternoon. And we will be talking about caffeine too in Parkinson's. And then finally, you can supplement your diet with vitamin D fortified foods such as milk and eggs, and also fish. And so that's a nice way to get the vitamin D that you need that we may not be getting since we all live here in Chicago throughout the year. And then I mentioned berries. So medications that are anti-inflammatory include berries, salmon, tuna, and then of course those leafy greens, and so those can help to decrease inflammation, and hopefully that's helpful for your cardiovascular disease, meaning heart disease, and also your memory in the future. Bone health is very important since, as Dr. Afshari mentioned, falls is a problem for many people. So we recommend getting calcium and vitamin D. As mentioned, as with vitamin D, calcium is fortified in basically orange juice, which is nice. You can have a little bit of that in the morning, and then also cereals, and of course, with some vegetables and berries. They can be fortified in the smoothies that you can purchase even at the store. And so if you're not getting it through your diet, it is okay to supplement. The Center for Disease Control recommends that all people 50 to 70 take in at least 600 units of vitamin D, and then over 70, 800 units of vitamin D. And that is holds true for patients with osteoporosis as well. Though if you're seeing an endocrinologist, if they say to be taking more, I would follow that recommendation. And so going back, so fortifying your foods is important, and then just knowing too that your digestion is slowing. And so once again, can't reiterate enough, we have to be drinking water so that we do not develop bowel impactions. And one way besides constipation paste, which includes prunes and other vegetables, having a cup of coffee in the morning can help people stay regular too sometimes. And so I'd like to talk a little bit more about coffee in Parkinson's disease. So many people may feel that their symptoms do worsen with after having coffee because it's a stimulant and it's activating. However, large population studies have shown for gentlemen that drinking coffee actually reduces the risk of developing Parkinson's disease. Unfortunately for women, it doesn't hold quite as true for women who have not undergone menopause or for those who are taking hormone supplementation. However, having a glass a day is likely not to be harmful for patients with Parkinson's, although the activating stimulant of coffee may worsen tremor for those who have tremor. There's also been evidence besides looking at large populations of people to see the progression of Parkinson's in them. There have been studies that looked at biomarkers in Parkinson's disease, and those who have had low levels of caffeine and the caffeine breakdown products have actually had higher progression. And so that's another study that kind of suggested the importance of coffee, or caffeine too. And then it's not just the caffeine in this mouse model that was done, but actually caffeine plus something else in coffee work together in combination and have been shown to be neuroprotective in mouse models. Of course, this has never been studied looking to see if we randomize people to coffee or no coffee, what do their brains look like under a microscope, since we cannot do that. But there is some growing, body of evidence that coffee can be helpful for patients with Parkinson's. So I just wanted to summarize. In clinic, I get a lot of questions about, well, doctor, should I be taking this? My patients are spending a lot of money on supplements. So I just wanted to go through a few of the most common supplements that I see people trying to add to their diet or thinking about adding to the diet. So I mentioned the Mucuna purins bean, and that levodopa actually was found from this bean. So should you be taking Mucuna purins? Well, fortunately, here in the United States, we have levodopa, which is a controlled dose and a stronger dose than taking in the Mucuna purins. So if you are in a far-off land without a pharmacy, maybe you should be grinding up this powder and taking it. But since we are all fortunate to be here with easy access to pharmacies, I would say no. If you are able to take the levodopa, I would just do that. Same thing, fava beans. People ask about that. You would need to consume a massive amount of fava beans to get the benefit, since the concentration of levodopa in fava beans is very low. What about vitamin E? This actually has been looked at with the DataTop study, which was conducted in the 1980s to the 1990s, looking at greater than 2,000 units of vitamin E a day, and there was no neuroprotection observed within that long study. However, 400 units, which is usually available in a multivitamin, is not going to hurt you. What about vitamin C? Likewise, it probably will not hurt you. If you're taking a multivitamin, you're getting enough. What about coenzyme Q10? Unfortunately, this was also studied, but the study was stopped early because it was futile, basically seen as futile to continue this. However, if it is within your means, once again, it probably will not hurt you, but the studies that have been done did not show that it was neuroprotective. And then this one, maybe you haven't heard of, but I've had enough questions about it that I wanted to bring it up just to answer this. Mannitol. There's a lot of excitement because there was a preclinical trial. What is a preclinical trial? An animal study that showed that mannitol could be neuroprotective. And, but it has not been studied in humans yet. And the reason why I do not recommend people take mannitol is because mannitol is a diuretic, a sugary diuretic. And so it's just going to dehydrate you from current understanding. Once the studies, or if the studies are conducted in humans and they support this otherwise, then I will recommend it. But at this time, I'm not recommending that people take mannitol. So this is a list of common supplements that people ask me about. The Parkinson's Foundation website has a fantastic list of supplements and diet recommendation, and it goes through the evidence quite nicely too. So I would recommend this website if you have any further questions about what you should be taking and if it's worth the money that you may be spending. Because I do have many patients who are spending almost $100 a month on supplements. So it's important to think about and also realize that $100 is $1,200 a year. That is a nice little weekend getaway that you could be treating yourself to. So just something to think about. So thank you for your time, and I will let Lucy introduce the next speaker.
It is with great pleasure It is with great pleasure. We welcome Angela Johnson, and she'll be talking about mindfulness in chronic disease.
All right. Well, good morning, everybody. I guess good afternoon, right? How's everybody doing?
Great.
Good, excellent. Well, my name is Dr. Johnson, and I am a doctor of acupuncture and Chinese medicine here at Rush. I'm part of the supportive oncology team and provide acupuncture as an adjunct to people not only with cancer, but a variety of chronic health conditions. It is a privilege and an honor to be here today to talk with you about the role of mindfulness. And so we're going to talk to you a little bit about mindfulness, and I'll take you through a couple really simple mindfulness practices. So, all right. So I'm sure it's been, even though it's only 12:20, I'm sure it's been a very busy, jam-packed day for everybody. So I'd like to offer us all the opportunity to just stop and pause and take a breath. And so I'm going to guide you through just a very short, gentle, guided meditation. So I invite you, if you're comfortable, you can either, allow both feet to be flat on the floor. And if you'd like, you can close your eyes or allow your gaze to rest somewhere on the table or the floor in front of you. And make any sort of adjustments that you need to your posture for further comfort. So maybe make your spine a little straight, but not too tight or tense. Relax the muscles around the eyes, the shoulders, the belly. And take 3 nice breaths at your own pace. 1 gentle and simple breath at a time. And as you do this, see if you can invite in a sense of ease and relaxation. Just the possibility of ease and relaxation. As you continue to breathe in and out at your own pace, see if you can let go of anything that is busy going on in your mind. Because right now there's nowhere to be, there's nothing to do, but just be present. And so I'm going to invite you now to allow your attention to rest on your body, just present on the chair. Noticing your feet connecting with the floor. Notice your body seated in the chair, your glutes, your back. And as I mentioned, the following parts of your body, just see if you can soften and relax these areas again. And so let's first check in with the stomach area. Sometimes we hold so much tightness and tension in the belly. And so see if you can just allow this area to soften. Notice your hands and arms, softening the fingers. Again, relaxing the shoulders. And what about the jaw, the cheeks? Just taking a moment to relax these areas. And if it feels comfortable for you, you can bring your hand to your heart as a way of offering yourself just some kindness and compassion for how you might be feeling in this moment in mind and body and spirit.
noticing what it feels like to give yourself that kindness. And then as you feel ready, you can gently open your eyes and come back into the room. So when was the last time that you took 2 minutes, 5 minutes, 10 minutes, 15 minutes to take a pause like that, right, during your busy days, to just take care of yourself, to breathe, to be present? It's been a while? Do I see some head shaking? Yes? Yeah. Why is it? Because we as human beings are absolutely just too busy. You know, we're busy juggling households and jobs and family, managing our own health, caring for our loved ones. We are overloaded and overwhelmed. And you mix all of our responsibilities with the everyday annoyances of news, crazy weather, Chicago traffic, right? That annoying neighbor or colleague. And the weight of life can often seem very, again, overwhelming. Whether we like it or not, right, stress in life is constant. And when it doesn't let up and it's paired, right, with feeling that we have no control over our circumstances creating it, it leads to chronic unremitting stress. And over again, research points to one fact, right? Chronic unremitting stress takes a stunning and toxic toll, impacting our body, impacting our mind, impacting our emotions and our behavior. We've all experienced this, right? When we're under stress, we notice when our muscles are tighten up, and when we experience headaches, right? From a mind perspective, our thinking might be muddled. We might be and feel more negative, right? From an emotional perspective, we might feel a little bit more irritated or feel depressed. And from a behavior perspective, we might be, right, more accident-prone, more restless, experience insomnia. And the thing about it is that over time, especially if we don't know how to manage it, the ongoing assault of stress begins to wear us down, zapping our brain power, compromising the immune system, and it can literally impact nearly every single organ in the body. While we don't have control over the stressors that come our way on a daily basis, there's really good research out there to support the fact that we do have control, actually how we react, and better yet, even respond to our stress, right? So we can break up with our stress. And one of the best ways to put yourself in the driver's seat of enhancing your own physical health and emotional well-being is through this practice that's called mindfulness. So I'm just curious, by a show of hands, how many of you have at least heard the term mindfulness before? Yeah, right? It's all over the news. Every time you go to the grocery store, there's mindfulness coloring books. Time magazine covers it. I mean, nearly every single, so about 1/3 of companies are now offering mindfulness training to employees. Mindfulness training is being offered in schools. It's being offered in, just across the country, and worldwide, actually. And so while there's a variety of definitions of mindfulness, the one that is most commonly used is this one from John Kabat-Zinn through the University of Massachusetts. And he defines it as mindfulness is awareness that arises through paying attention on purpose in the present moment and non-judgmentally. So the thing about mindfulness that's really interesting, I'll go back to this one, is that, as I mentioned, this is hard to do because I like to move around. So as I mentioned, stress is a part of everyday life. But the great thing about mindfulness is mindfulness provides a space between, that gives us a space to respond to a stressful situation in a more skillful and helpful way. And so with mindfulness, again, there's an awareness of our thoughts, what we're feeling, what we're experiencing in the present moment, And then we can respond by taking a couple breaths, by bringing compassion to ourselves, by doing a mindful walk, so that we're not constantly allowing the impact of stress to have a negative impact on our mental health and our emotional well-being. So, and this is in comparison to what happens when we don't have this mindfulness as a kind of a pause in our life, right? The stimulus of stress, and we have an automatic reaction, and then we keep ourselves in that constant state of chronic stress, which isn't good. And so some examples of mindfulness practices include mindful breathing. So that beginning kind of mindfulness meditation that I took you through was kind of like a mindful breathing exercise. So there's things like mindful eating, mindful listening, loving kindness and compassion practices, which are beautiful. There's a body scan, there's mindful walking, there's a 3 good things practice that's a really wonderful. And the great thing about these practices, you guys, is that you don't have to go anywhere special to do them. You don't have to go to a gym and sit in a room with the lights down and your eyes closed and sitting in, with your legs crossed for 45 minutes. I mean, we were all in this room together and we practiced mindfulness to help us be more fully present. So, and the benefits of mindfulness, there's a growing body of research to show that the benefits of mindfulness are really pretty incredible. Not only does it help you have more energy because your quality of sleep is better, but it helps to boost the immune system and also increases your level of happiness. There's also research to show that benefits the brain health. So it actually slows down the aging process. It boosts the part of the brain that's related to decision making, to our attention and focus, and to helping us be more empathetic. It reduces stress. For those people who have high blood pressure, there's lots of studies that show that mindfulness helps reduce blood pressure. It also has a positive impact on people who suffer with chronic pain, and it reduces anxiety. So not bad. So I'm going to take you guys through a little bit longer of a mindful breathing practice. So I'll take you through that in a minute. One of the things that why mindful breathing is so wonderful as a way of helping us be present is that we never breathe in the past. We never breathe in the future. We are only ever breathing in the present moment. So if we are ever in those situations, maybe, you're stuck in traffic, or whether you're stuck in traffic or you're trying to go to bed, and your mind is racing through, all of the stressors and things that are going on in your life. You know those moments where you can't just relax because you're just caught up in the worries and the what-ifs of life. And so as a way to help you be more present and bring yourself compassion for what you're experiencing, mindful breathing is a wonderful way to do that. And the thing is that a lot of times when I give talks and I typically do like a 4 or 6 week series to help people really dive into mindfulness practices, is that sometimes people say, well, I love this whole idea of mindfulness, but Angela, I just don't have time. And I remind them, guess what? You breathe 17,000 to 30,000 times a day. You have 17 to 30,000 opportunities to be mindful. So you can just put that in your back pocket and think about that. So I'm going to take you guys through a practice, again, where we're just going to be seated in our seats just like we were before. And so I'll guide you through this practice, and then I'll ask for some of your input on the experience. Okay, so if you're comfortable, you can go ahead and close your eyes again, or allow your gaze to rest on the table or the floor in front of you. Again, making any sort of adjustments that you need in your seat for further comfort. And so it's always nice to have the spine a little bit more straight, upright, but not too tight or tense. Having a posture that embodies a sense of dignity and strength. And so here we'll begin by simply noticing our body present on the chair again, the various ways our body makes contact with the chair. And so you can feel or notice your legs, the places where your legs connect with the chair, the weight, the pressure, the touch. The back. Softening the muscles in the belly, the face, the arms. And so for the purposes of developing concentration, we're going to focus again on the breath, using the breath as a concentration object. And the idea is to simply allow your attention or your awareness to rest on the sensation of the breath, just one breath at a time. And so for this particular meditation, we're going to begin by finding the place where the breath is most comfortable and enjoyable for you to focus on. And so for most people, that's just below the nostrils, at the chest, or at the belly. And so take a couple of moments to determine for yourself where you'd like to rest your attention on the breath, either at the nostrils, the chest, or the belly. And now that you've found your spot, let this area be your home base or your anchor for your focus. And so for the next several breaths, just allow your attention to rest on one entire length of each inhalation and exhalation, from the beginning to the middle to the end. Again, just one breath at a time. And the moment you notice that your mind is wandering off of the breath, which it will several times, know that that's the natural wiring of the mind to wander, and gently shepherd your attention back to the breath. Make a mental note of the word wandering, and bring your attention back to the breath. So go ahead now on your own for the next just several moments, giving yourself this gift of pausing and being present. You are changing the physiology of your body for better health and wellness. And if you find that you need a bit more help keeping your attention anchored on the breath, just consider making a mental note of the word in every time you breathe in, and out every time you breathe out. So there's a gentle alertness, a curiosity about the breath in a way that we don't normally do during the day. And here, too, we can take this opportunity, if you're interested, before this meditation ends, to bring your hand to your heart as a way of offering yourself, just extending a sense of warmth and kindness and compassion to yourself. For taking this time to be present, knowing that this experience is building an inner resource for you to improve health and well-being. And as you feel ready, you can gently open your eyes and come back into the room. So I'm curious, it's a little bit hard because I typically like to walk around the room, but I'm kind of stuck here to this microphone. So if a couple people don't mind just sharing one or two words about what that experience was like, just to stop and pause and breathe, would you mind just raising your hand and sharing one or two words? Yes. Relaxing. Nice. How many other people found it, just by show of hands, found it to be relaxing? Okay. And I'm going to get to you in a second. That's a beautiful thing, and I really appreciate that you were brave enough to, number one, to share that information. The thing about mindfulness is that while many people do this practice to relax, that isn't the end goal. But if you end up experiencing a sense of relaxation as a result of your meditation, like, that is awesome. So just know, for those of you who did not raise your hand, and you're like, well, I don't feel relaxed. Did I do something wrong? You did not do anything wrong. Your mind and body still benefit, all right? But it's just a super triple bonus that you felt relaxed. Yes? She felt like everything was slowing down. Tell me a little bit more about that.
So my jaw started to slow down.
Yeah.
I felt like if I was in touch with my blood pressure.
Yeah. Interesting.
I could feel it slowing down.
Yes. Yes. When you do it, so she felt like things slow down. When you do these practices, you are literally inviting in the relaxation response, which is the opposite of the fight or flight response, which is related to stress. So you literally empower yourself to, like I said, literally change and have a positive impact on the physiology of your body. Your blood pressure slows down, your breathing rates slow down, and you're more fully present. A lot of times when I talk to people about mindfulness, they say, "Oh my gosh, I did this breathing practice, this breath practice for 2 minutes, and I feel so tired." Well, you know what? This is a way of helping yourself become aware of how you're feeling. So it's kind of insightful. It gives you information. So, running out of time? Okay. All right. Darn it. I just would love to talk all day. So anyway, we have, again, 17 to 30,000, almost 30,000 opportunities a day to practice just even the simple mindful breathing practice. Remember that these are wonderful inner resources. You don't have to go anywhere special to do them. We cannot stop the waves, right? The waves of stress coming at us every day, but you can certainly learn to surf. So you get a surfboard, you get a surfboard, you get a surfboard, everybody gets a surfboard. Well, okay. So, all right. But anyway, so again, and just to wrap things up, remember, we are human beings, not human thinkers, human doings, or human feelings. Our essential nature is to just be, right? So instead of, we do, go all day long, and so this is a wonderful way to just tap into our sense of human beingness, if that's even a word. So anyway, thank you guys so much.
Okay. All right. So if we could have all the panel, all the speakers come up to the stage for question and answers. And anyone who has a question, an index card, please hold it up and we'll be walking around for it.
Testing. Testing. We can share. Hello?
Hello?
That would be. No, that would be downloaders. Okay, shall we get started? Okay, so we'll get started answering some of these questions. Somebody asked about are probiotic supplements beneficial in the gut connection? That's a great question. There is a lot of research being done even here at Rush about the immune system and the gut and its relationship with Parkinson's disease. I think that probiotics are overall beneficial, and that is something that would be worth taking. However, there hasn't been a lot of evidence or studies done to show that probiotics reduce the risks of Parkinson's or to directly link probiotics to improvement of Parkinson's disease. Do you want to go ahead? Or you try?
Oh, it does? Okay, good. All right, so someone asked, do you offer acupuncture at Rush? I do. I've been offering acupuncture at Rush since 2007. And while I am primarily located in the cancer center, I see a variety of patients.
Okay. Can you hear me? So one question was, I think this has to do with REM behavior disorder. Yeah, one question was about REM behavior disorder, and is there anything to reduce this? And so there are several ways that you can treat REM behavior disorder. The first-line treatment of REM behavior disorder, that's the vivid dreaming or dream reenactment, and it can manifest just as vocalizations, but also movement. The first thing to try is melatonin, and generally we have to use higher doses of melatonin that's available commercially. So usually it's about 3 to 5 milligram melatonin doses that are available in stores, and we generally try and push up to as high as 15 milligrams of melatonin and try that because it's very kind of a benign, non-sedating medication. And then if that fails us, then we can try higher kind of sedative type medications like clonazepam. And obviously with REM behavior disorder, you definitely want to protect yourself in that if you are moving a lot, you want to safeguard the bed area, I guess, with cushions and having a generally lower bed so you don't fall off like a high bed. So just some kind of non-invasive strategies to keep in mind.
All right. So I have a lot of good questions here, so I'll try to get through as many as I can. Somebody asked, is almond milk a good source of vitamin D versus I think 2% milk or milk? In general, almond milk and milk can be fortified with vitamin D. The regular milk tends to be whole milk. And in general, as I mentioned, Parkinson's is associated with weight loss. So I would, splurge and allow yourself to have whole milk if you want it. And then almond milk, I would just be careful to look to see if they fortify it with vitamin D, because some do, some don't, but often they do.
Okay, so I know this question is going to be popular. So someone is asking about medical CBD oil and our opinion on this. So I know that, marijuana has officially been approved in the state of Illinois. And so, we wrote about this in one of our recent PD newsletters. And so there really is not enough objective evidence as to what CBD helps with in terms of Parkinson's disease, because as you know, it hasn't been legal here, and people have not been able to study it in a more formal, controlled setting. And so we're not quite sure what it exactly can help with in terms of Parkinson's. But I think in general, knowing the medicinal qualities that it has, I guess CBD oil can be helpful for things such as sleep and anxiety. And so I wouldn't say that I'm completely against using it for that purpose. But in essence, you know, we are very much kind of researchers and evidence-based doctors, and so we don't have much to go off of in terms of making really good recommendations to you with regards to CBD.
Okay. All right. So I have another question, which is tea as beneficial as coffee as far as caffeine and the progression for Parkinson's? So coffee was studied, and tea is there are a lot of different types of tea, and so tea has not been as well studied as coffee and the coffee breakdown products. And so tea tends to have a caffeine product called theophylline, and so that from my understanding, has not been well studied like coffee has been in regards to Parkinson's disease.
And then one question says, what kind of PT is the right kind of PT? So this is an interesting question and something that I'm interested in as well in terms of a researcher. A lot of our first-line treatment for falls prevention and preventing falls is physical therapy. And not all physical therapists are created equal. There are physical therapists that are neurologically certified, so they have intensive, more specialized training in neurologic conditions. However, there's very few of those physical therapists. In fact, at Rush, we only have one serving the entire Rush community. And so, unfortunately, there isn't a huge incentive for physical therapists to become neurologically certified. But I think the important thing in terms of physical therapy is finding a person who at least has experience and has at least more than one patient experience in terms of working with patients with Parkinson's disease, and that in itself can be helpful in that they've been able to have some practice in terms of certain strategies that we use for Parkinson's patients, especially when it comes to freezing of gait.
All right, and this question I wanted to address because anybody who takes rasagiline may be faced with the pharmacy telling them not to take this medication with their other medications. And the question was, are there any meds that I should avoid with rasagiline? Rasagiline theoretically can cause a serotonin syndrome with certain medications that increase serotonin, such as tramadol or antidepressants that act on the serotonin pathway. However, this we find in practice is generally a theoretic risk, and I would consult with your provider who is prescribing rasagiline, but in general, this is a very safe medication to continue while you are on an antidepressant or pain medication such as tramadol or other medications that can act through the serotonin system. So, of course, consult with your specific neurologist or provider, but overall, you will get a flag at the pharmacy. But in general, for my patients, I say it's safe to continue, since we also use low doses.
Okay, and then one question is, are hot flashes or elevated body temperature a symptom of PD? And I would have to say that probably yes. And so this is a symptom of kind of that autonomic dysfunction that we talked about. So some of the automatic things in your body, like blood pressure control, bowel transit, and temperature regulation. That's an automatic thing in your body that needs to kind of take care of itself, and it does become affected in advancing disease. And so you can experience kind of cold intolerance or excessive heat and sweating. Obviously, in postmenopausal women, this can also be an issue because of that in itself. So the answer to this question is yes, it can be. In terms of treatment, I can't think of a specific treatment for this, unfortunately. I don't know if Natalie, you have any ideas or...
Yes, it's a very hard thing to, treat. And so in general, just looking for the other medical causes. Otherwise, in general, we don't have pills that can help with this.
Yeah, I have had some success in treating hot flashes with acupuncture, and so I mean there is some scientific evidence to support its use for that symptom.
Fabulous.
So now we could give all our presenters a great round of applause. Thank you very much, Dr. Upshawi, Dr. Johnson, and Dr. Wittick. Now what we would like to do, we have a special presentation. So I need everyone in this first row to kind of pull their chairs behind in the back on the aisle and over a little bit. We have Fonseca Karate, and they're going to do a demonstration for us during our break. So if we could help you move your chairs, that would be great.
Yeah, because we're going to do it in the newsletter. Where did you want to
I think so. You guys ready? Ready? Awesome. All right, as everyone is taking a break, okay, got it. I just wanted to quickly introduce the amazing crew in front of you. So we have instructors from Fonseca Martial Arts, which is a group of karate studios throughout the Chicagoland area, and our amazing Kick-Out PD students. So this is just a sampling of some of our folks who are diagnosed with PD and are really kicking its butt by using karate. So I will talk a little bit about the rationale behind that, but what's way more impressive and more exciting is to watch them do their thing. So with that, I will hand it over.
Hi, my name is John Fonseca. I'm the owner of Fonseca Martial Arts, and it's a real pleasure to be here. Thank you for having us. This is Sensei Salgado to my left. Sensei is a world referee and has been training, teaching in the martial arts for many, many years. He's world-renowned. And to his left is Sensei Dan Milosevic, and he is from Macedonia and also a world referee. So both of these gentlemen are highly accomplished, and together we've put together a wonderful curriculum with the help of Dr. Fleischer, and we have all of our students to their left, who are just doing a phenomenal job in the program. They've already moved up through the ranks to the first belt after white belt is yellow belt, and then orange belt. So our orange belts were training in the original 10-week pilot study, and they've stayed on, continued training with the rest of the participants in the next 6-month study. But we're going to show you today some of the movements that we do. We do a lot of exercises for warming up the body, working on posture, on breathing, on meditation, mindfulness, focus. Certain exercises challenge balance, coordination, body control, and the kata, which are the forms. It's a bunch of karate moves put together into a routine. We'll try to, we don't have a lot of area right here, but we'll try to maybe modify that and do part of the kata so we can show you how we transfer the weight and change direction and work on maintaining balance with different movements. So without further ado, Sensei is going to start the demonstration. Thank you.
Thank you, Sensei John. So for us, it's a real pleasure to stay here with our dear group. Now, for us, actually, we feel very proud and happy with the result with the program. Because I remember 1 year ago, I think so, we started with this program. For me, and I'm thinking for you, was a big challenge. Because for us, it's the first time we do something like this. But when when we saw the result, oh my God, it's very important for us because I can see their face. Now you look happy. When you move, your body is different. I remember when many people, when we start with the short step, because with the PD, they lose the balance, you know. And when we lose our balance, we lose our confidence with ourselves. But when we recover our skill with our body, we feel better and we feel confidence with ourselves. And I think we feel more happy. That is the idea. We deserve to be happy. Thank you. I want to start now. We're going to move in our spot. We're going to show our work up and after we're going to move in group. Okay? Stay. Okay. Okay, look at it. Every time we start with our feet. Simple. Because we need to get a good posture, and then a good muscle. So, each knee and we turn the other. Each knee, you can see how we move our feet. Each knee, stand. Now grab the mat on the floor with the big toes. Okay. Now bend your toes. Muscles very important. Okay. Now put it on your body first, and we're going to squeeze our foot. This is very important. We need to use the ball of our foot, not the blade of our foot. Before we get balance, the blade, put your balance. Each, and kick, go, kick. Ready? And your knee, each, knee, and kick, go. Okay, now, each, knee. We're going to increase our blood circulation. Each, and kick, go, rock, kick, punch, shoot. Your knee up now. Higher, each, and you can knee, and kick, go, rock, kick, punch, shoot. You very good. Now, pay attention. We are going to squeeze our feet simultaneously. Again, like this. Like this, because if you do only one, you lose our balance. So, let your knee work your edge. I'm going to skip. So, forward. Eight. One. Six. Up. Right. Six. Touch. Two. You. Now, left arm, a point to the left side, and now we're going to squeeze our feet, and we're going to strike. Ready. Eight. One, ready, 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 two. Good, keep rotation, don't forget that. Ready, sit. Ready, two. Now we jump, two. Stop. Okay. We're going to work with our hip, our weight. Circle, 5 inches. Tension in our core. Very, very important to work with our core. Other side. Hip. 1, 2. Go now. Stretch. Each. Inhale. Exhale. Each. Inhale. And exhale. Yeah. Now, very important. Shoulder muscle for our posture. Not like this. So we need to get strength. Ready? Each. Deep. 1, 2, go. Rock. Forward. Each. Deep. 1, 2, go. When we move our shoulder, don't do it with your arm. Always feel your try to sit the shoulders together. Look at straight leg. Each. Deep. 1, 2, go. 1, 2, 1, 2, go. I think we are working with all of our joints, knees, ankle, waist, shoulder, now with our ribs, each knee, ankle, cheek, both, rump, feet, eyes, beautiful. Otherwise, each knee, ankle, cheek, okay, ready? Now, inhale, neck, very important. Ankle, cheek, both, rubber. Now, to the side, to the knee, push down your shoulder. And with your hand, put your head, and we are going to stretch our neck muscle. Our breathing is so important. There's energy, and we get psychomotor coordination. 1, 2, 4, 5, yeah. So now, our posture. Look at my neck. You put it like this. It's heavy for our body, so we get tension. Now, exercise for our neck. Cheek. Go. Go. Cheek. Touch. Cute. So, right? The idea is to align our spine. Our core. Work. Okay. Okay. We're ready. We are going to start with our basic moving. Karate is martial art. So that is the idea. We start with defense, block. If somebody wants to tie our face, we can block. Okay, come forward. Nobody is afraid. Everybody can see. Every time when we practice between us, we respect. We wish you ask because we need to get it. So I'm going to point to my next page. He says Jordan, means high level. No, it's okay. This is karate, traditional karate. But we can do like this. Block. We are working our muscle, our strength, and our coordination, our talent. We're going to start with our block. Right block. Go. Breathe. 2. Shout fire. Yeah. Very good. So now we start with if somebody wants to attack to our chest, or maybe our face, but now we're gonna choke to our chest. Say now, shoot up. It's very important how I use my hip and my eye. You can do many. But now we're going to do more. So each knee. It's not necessary to crush until be like this. when you get good experience, it's not necessary to use a lot of strength. All they use this energy, like variable. Thank you. That's one. In one up. Get ready. Set in your ears. Now, it's very important how we move our hip, our core. Tension with your breathing. Ready? Excellent. And now we're going to do immediately downward block. If somebody wants to kick, you block. You ready? Get up alive. Yes. Crawl again. And now. Straight back. Like a little bit your knee. Go. Get up alive. Downward block. Go. Excellent. Straight back. Rock. Excellent. Punch. Excellent, John. Stop. We use different extensions. The idea is to use different extensions to get more balance. And then we are going to show force extension. When we do force extension, relax with our leg muscle. That is the idea to do it. So exactly extension. Hold it straight back. We are going to do punches now. Ready? Relax. Breathe. Breathe down. What about our breathing? It's very, very, very important. Yeah, I think about something about the breathing. I do some special exercise for the breathing. Why? Because when we breathe properly way, we get more coordination between my brain, my body, psychomotor coordination, and we feel more relaxed. Everything works better. That is very good for part of meditation. How? Breathing. When we breathe, usually normal breathing is our like this, look, my chest. If I see somebody, okay, use the kind of shoulder. Yeah, you feel that? Receive! Without! Receive! Without! But, that's good. Breathing. When you use your core, receive, without. Receive, without. It's very good example. You know why? Because, we align our spine when you use your core and you get more balance. So it's a, if I have, and our center of gravity is lower. Well, our center of gravity is here, low under our belly bottom, here in the middle. So if I have a butt position like this, somebody, I'm going to fall. Same idea, but I put my core here. No? So depends how we use our body. Everything is possible. I think it's our body. Okay. Now we are going to show. No, okay. 1, 2, 3, 4 there, please. 2 lines. Facing. 2 lines. And you there facing 2 lines there. 2 lines. 2 lines here. 3, 3, 2 lines, 3. Because we are 3 here. Okay. Yes. Yeah. So what is the idea? We are going to move. This group move after that group. That is the idea. Okay? Yeah. Ready? Thank you, Sudachi. No, come on. You don't move, please. You may. The forward response. And don't move. Show me your back straight. Your core is strong. Excellent. We're going to do 4. Super high and attitude. Yeah! Now, backward with rising block. You are going to defend. Ready? Don't spread your weight to your back leg. Here. 4. These are 4. And another one. Yeah! Oh, enjoy. You do this.
Extend. Left leg forward, downward dog. Each. Yeah. With the hands in front of you, we're going to punch forward. Each. Each. Stop.
Like a motorcycle.
Yeah.
Yeah.
You go backward, inward block. The hand like this.
Even for us, back.
Each.
Remember, very clear.
Each.
Very.
Stop.
Yeah. Thank you from me. Attitude. Excellent. Very good. Oh, very good. Now, this group. Joey, I sent to Sudachi. No, come on. Yeah. Now go forward once again. 4, 8. Jordan. Please. Now, they learn Japanese. Yeah. Backward with get on the right. Get on the right, downward blow. I am stop. Okay. Together. Stop. Like this. Face to the. Yes.
Okay, let's give these participants a big round of applause. I just want to commend everyone here on all of the work that they put in. It's amazing to see the progress that everyone has made here, and also the bonds and the friendship that's formed through martial arts training. That's always been one of the things that I've appreciated about it. I grew up doing karate. I started when I was 6 years old, and you're just sweating and training and alongside of people from all walks of life, and you just form these really strong bonds. It's a beautiful thing to see, and it's also just wonderful how much work and determination and focus that all of these students have put in. So I just want to say thank you. Thank you for your dedication. Thank you. And the last thing I'll say about karate is that one of the nice things about karate is what you put into it, you get out of it. You can progress at your own rate. Every single technique can be modified. So you might see one practitioner will do a long, deep stance, and that can be modified to a shorter stance. You go at your own pace and your own comfort level. It's non-contact. We don't strike each other. But at the same time, it's very empowering because you're striking pads and focus mitts and targets, and the senseis will try to push you, and it's just a really empowering, very, very wonderful art. So thank you for your time, and let's give them one more big round. Thank you.
We cover a lot more techniques, but with the time, it's impossible to show.
Well, there are 2 other breaks for demo.
Okay, and now we're going to show another. Thank you very much. Awesome.
Hello. Hello, everybody. I just have a real quick update on for anybody who valet parked. We have arranged for the valet driver to stay until 4 p.m., but it is a hard deadline, so we apologize. At 4 p.m., the valet will be gone. So if you have valet parked, we do apologize. You may want to head down there a little early. He will be leaving promptly at 4 o'clock.
Sorry. All right, we're going to get started with the next talk. That is a pretty hard act to follow. It is my pleasure to have to follow that act because they inspire me on a daily basis. So my name is Jory Fleischer. I'm one of the other movement disorders neurologists here at Rush. And I'm going to talk to you today about exercise and karate in Parkinson's disease. So these are just briefly my disclosures. The research that supports the karate has been supported by Joyce DeMuth and George Harvey. So what do we know about exercise in Parkinson's disease? Can everyone hear me okay, by the way? Okay. All right. So we know exercise improves brain function in many ways. And this is even outside of Parkinson's disease, right? Hopefully every single one of your doctors, no matter whether they are cardiology or your primary care doctor, maybe even your podiatrist, has told you that exercise is good for you. Yes, exercise is good for you, right? And so it improves your heart and lung function, which leads to improved motor function, improved attention, improved cognitive speed, things that all of us want. And in general, aerobic exercise improves attention, executive function, and memory, specifically when it's been studied in healthy older adults. And if the question is, what do you mean by healthy older adults? Studies differ on how they define older, sometimes 60, sometimes 65, sometimes 70. I think it's a state of mind. But we know specifically in older populations that exercise really can help with many things. When it's been looked at in folks with Alzheimer's disease, we know that exercise, particularly aerobic exercise, helps memory, helps executive function, so juggling multiple things in your mind, thinking about decisions, and it helps with balance. So how exactly is this happening, right? It sounds a little hand-wavy. Exercise is good for you. Go exercise. It helps your brain. There are actually a number of different ways, and it seems like almost every journal article that comes out is proposing a new pathway by which exercise is physically changing your brain. And that's wonderful, because it's not just one pathway. There are many things going on. So in animal models of exercise, this is tiny little mice who are given basically mouse version of Parkinson's disease. Those mice who are put on a wheel and forced to run, they perform better on cognitive tasks than animals who are not given these, put on the wheel, right? This is lovely. We are not mice on a wheel, so it's a little bit harder to sort of translate all of these things. But what we've found is that long-term exercise, particularly long-term running in animal models, leads to increased growth of neurons, actual like increased growth in the brain, particularly in the hippocampus, and that's the area that's crucial for memory. It leads to increased release of brain factors that build new connections or synapses, and it leads to increased release of synapse-forming proteins. So not only are the brain cells sort of connecting to each other, but they need to connect and they need to be supported in those connections, sort of like have all of the good juices kind of flowing around to make sure that those connections stay. And exercise seems like it promotes the connections and all of that good environment around there. So what do we know about specifically how does exercise improve function in people with PD? So it looks like moderate intensity aerobic exercise, stuff that gets your heart pumping, it gets you sweating. You should be able to get a sentence out but not have a full conversation, okay? And that could be different for everyone. But 45 to 60 minutes, at least 3 times per week, shows improvements, especially in executive function. And again, what is executive function? This is not, can you delegate things to, people in the C-suite? Executive function means decision-making. It means, how do I do this first and this first? If I have a complex task, what needs to happen in order for something else to happen? And that's a particular area of thinking that can be impaired in people with Parkinson's, and this has been shown to help. There are great studies looking at progressive resistance exercise, so weight training and resistance, that have shown that when people with PD participate for 60 to 90 minutes at a time, twice a week, that leads to improved working memory, executive function, and attention, right? This doesn't mean that you need to go out and be Iron Man, okay? This means starting with small weights, starting with the resistance band, and ideally starting with someone who knows how to guide you in those exercises so that you're doing things safely and not harming yourself. And in one of the bigger trials to come out, which took place here at Rush along with other centers, they studied high-intensity treadmill exercise, so 4 days a week, aiming to achieve either 60 to 65% of your max heart rate or 80 to 85%. And they found improved mobility compared with moderate, so the high-intensity folks did better than the moderate intensity folks, and everyone did better than the folks who did not do anything at all. So I get asked a lot in clinic, is there something that I can take to slow down the course of my Parkinson's? There is not a pill that we have right now to slow down the course of Parkinson's. All of our medications are symptomatic treatments, meaning they're covering up the symptoms. They're trying to improve quality of life, improve how you are functioning, but none of them so far have been shown to slow down what's going on in the brain underneath, except exercise. Seems like this has the most evidence to say that this is slowing down the course of the disease to the extent that we can. So in big studies, I showed you the animal models, right? But no one is a mouse on a wheel. What about people with PD? When people with PD are looked at and we compare the folks who are lifelong exercisers to the folks who are lifelong couch potatoes, the lifelong exercisers, maybe not surprisingly, do better. But if we especially look at people who've been sort of couch potatoes and then take up exercise, they get moving, even after the diagnosis, they do better than the folks who did not take up exercise at all, right? So it is never too late, okay? That's the main take home, but we do need long-term prospective research to confirm this. But it seems like if you take nothing else away, this is the thing, is that the more you keep moving, the more you will keep moving. Right? And so any kind of movement seems like good movement. So from that treadmill study that I mentioned, the SPARK study, what they found, again, is that people who exercise at high intensity did a little bit better. Let's see if we've got, nope. So the farthest left is the maximum heart rate folks, and so they had a slight improvement in their Parkinson's disease rating scale compared to the moderate folks, and especially compared to folks who are not necessarily doing exercise at all. So this is the other question besides maybe medical marijuana. This is the second question that I get asked most is, but okay, that's nice that I'm supposed to exercise and it's nice that you're saying like all of these things are good, but really like what's the best one, right? The best one is the one you'll do, right? Whatever that is, honestly, I am thrilled and inspired and amazed by my karate, the students and our instructors and all of that. But if you are sitting there and going, that's lovely, but there's no way I'm ever doing that, that's okay, but find something that you will, right? And maybe that's a treadmill, maybe that's swimming or water aerobics, maybe that's walking your dog vigorously or scheduling time with the grandkids and chasing them around and really making an effort out of, hide and seek as an aerobic activity. Fine. Whatever it is that gets you moving, that's great. It's the thing that keeps you moving. So just as much as we have a prescription for the various medications in terms of how much and how often, right, this is really, as far as we know today, what the prescription for exercise should be is at least a total of 150 minutes per week with your heart rate elevated, sweating, and enough to feel fatigued but not exhausted and not in pain. Do you need to go out tomorrow if you have been doing 0 minutes of exercise a week and aim for 150? No, you will be miserable and you will hate me. That is not the goal. The goal is aim for 10 this week, right? Aim for 20 next week. And it doesn't need to be, 30 minutes 5 times a week. It could be 10 minutes here, 10 minutes, between lunch, 10 minutes walking around in the evening, something, starting somewhere and building up to that 150 minutes or more is hugely helpful. So, this is directly what happened, is if you have an idea, if you are thinking about, well, there's this exercise that I used to do or something that I heard of, is this good? So a patient of mine came to me and said, so I'm doing all the things. I'm doing yoga, I'm doing Pilates, I'm doing aerobics, I'm doing weight training, and I've heard about all this boxing, I'm doing boxing. What about karate? Has anyone looked at karate for Parkinson's disease? And at first it sounded a little bit out there. I hadn't seen anything. And then I got to thinking about it and thought, well, okay, it has the balance and the core strength and the fast movements and these large amplitude movements that you saw. There may be something here. So we started our study called Kick Out PD. So most studies and grants, they're supposed to have a catchy acronym, right? So this stands for karate intervention to change kinematic outcomes in Parkinson's disease. We're very fancy. We're terrible at parties. So Kick Out PD we launched last summer. It was just 10 weeks of our folks going to karate classes twice a week for those 10 weeks. And these were specific karate classes designed for people with Parkinson's disease. And they were adapted to be aware of the things that can go on with Parkinson's disease, but these were not in any way watered down, dumbed down kind of classes. This is the real deal, just keeping Parkinson's disease in mind. And we've had the most amazing partners with Fonseca Martial Arts and the instructors. And so this was for people with Parkinson's disease, Hoehn-Yahr stages 1 through 3, which means sort of early to middle stage disease. So people could have some trouble with their balance. They could be falling. And what we wanted to know was basically, if we build it, will they come? And if we build it, will they stay? Will they keep coming? So what would the dropout rate look like? What would attendance look like? And then secondarily, does this help people? Will we start to see a signal? So we wanted to look at mobility. We wanted to look at anxiety and depression, because there's some evidence that anxiety and depression can get much better with exercise, including in Parkinson's disease. We also looked at attention and concentration. And finally, we looked at quality of life and global impression of change, meaning, hey, compared to 10 weeks ago, do you feel better? Do you feel a lot better? Do you feel about the same? So here's what we found. So this was, again, a small study. We did not have a control group, but we looked at, of our folks, we enrolled 19 people. 15 out of 19 completed the study. And our attendance, the adherence, was 87%. So twice a week classes, people went 87% of the time, which for an exercise intervention is pretty darn good. Who did we enroll? So 53% women. And I put this on here because there's one small study of karate that came before this that was published out of Germany. And our good colleagues in Germany, their study design was they had a dance class for Parkinson's and a karate class for Parkinson's, and you could enroll in one or nothing. And they compared the folks who enrolled in karate to the folks who enrolled in dance to the folks who decided, nah. Right? And not surprisingly, the folks who enrolled in something did better than the folks who enrolled in nothing. And they said, aha, we had more men enroll in karate and more women enroll in dance. And thus karate will be a wonderful intervention for men with Parkinson's disease. I think you can see from our students who are up here that this is not a men-only thing, and very empowering, and that's what our initial results showed, is that 53% of our students were women. The median age was 68, but we had quite the range. And on average, our folks had been living with their Parkinson's for about 6 years, but our range was anywhere from 2 to 20 years of Parkinson's disease. And the vast majority of folks were at Hoehn-Yahr stage 2, meaning they have symptoms on both sides of the body, but not necessarily impairing their posture or balance yet. So what did we find? The take-home point, aside from the fact that people came and they kept coming and they kept going to classes and sticking with it, was something that we were very surprised and very cautiously optimistic to see, which is that when we asked about quality of life using a validated scale, so a particular 8-question survey that gets at different things that impact people's quality of life in Parkinson's disease, over just 10 weeks, we found a significant improvement in quality of life compared to those folks' baseline. Also, when we asked people sort of on a scale of 1 to 7, 1 being, I'm the same as I was 10 weeks ago, or I'm worse, and 7 being, I am considerably better, and this has made all the difference, 87% of people endorsed feeling moderately or considerably better. We asked people on day 1, before they started classes, what do you hope to get out of this? Like, what are you coming into karate expecting? And we just had them write that down. And then after they'd gone through the 10 weeks, we gave them back their original goal and said, do you feel like you've achieved that? And 100% of people felt that they had achieved their own personal goal for the classes. 100% say they'd recommend it to a friend with Parkinson's. And 100% intended to continue. We also did some focus groups to ask, what are we not asking about? What did we not think to ask about? And one of the things that I think has been most meaningful and most exciting for us was the sense of camaraderie and shared experience. And I think you can get this with a lot of different ways of getting together with other people with, the same condition. But I think we really heard that resonate with our participants, was knowing that they were in a safe space where everyone else around them has the same diagnosis and everyone's Parkinson's is different, but they all sort of had the understanding of this is a safe space for me to be. Someone said, I felt like I could sort of check my Parkinson's at the door and just go on and be in class. And I think that's really exciting. So we found a positive effect on overall well-being, People were really, really complimentary of the individualized attention and have all of the amazing words to say about the instructors. They felt treated like others. They felt that they could overcome their limitations. And importantly, they felt like they were incorporating these lessons into their everyday life. So this is based on just snippets of what individual folks said, but very exciting, and we're following up on that. So let's see if this will run. Do we know how to get this to run? No. Anyone know? Kimberly, anyone know if we can make the documentary run? Or not? Well, hold on. Let's see if this works. Oh. Hey. So we partnered with the documentary filmmaker.
So I'm here participating in a research study for Parkinson's, and hopefully we'll discover that karate will help keep people with Parkinson's fluid and deter the degenerative effects of Parkinson's.
I'm coming to my first night of karate. I have no experience or any knowledge about what I'm about to get myself into, but I figure I will be yet another experience in learning something about humility. My only preconception of karate is the Karate Kid movie where we did that sound like off.
If you can go a little faster, you can go a little faster. Now go out, ready? Go!
The change over the 2 months is primarily with regard to balance. I notice that my balance is much better. I'm looser. One of the problems that I've had is a slowness in movement, and this has helped improve on that considerably.
I didn't really believe in the chance of significant change, but significant change has occurred for me. I was surprised at the level of improvement, and it's been a wonderful experience to be with all of the wonderful people who have taught us. It's just a remarkable environment here.
We started the Kick Out PD karate program just about 10 weeks ago, so this is our last week, and it's just been an amazing experience. Sensei Salgado has just done a wonderful job with the classes. I've really enjoyed working alongside him and seeing the improvement that all of the students have made.
One of the questions that I get asked the most is, what can I do? How do I slow this down? How do I stop this disease? And we don't have a medication that slows us down or stops it. The one thing that we know seems to slow down the course of Parkinson's is exercise. The idea for this study really came about from a patient saying, I have this idea, I have this connection to karate. Has anyone looked at karate for Parkinson's disease? And we looked to the literature, and no, there wasn't really much there. And so we brought this together and said, yeah, there might be something to this.
It's like a support group. I mean, we are all people with the same illness, and we understand each other. When you have trouble getting up off the floor, everybody's standing there staring at you like, why can't you get up? It's much more positive.
So, again, we were really cautiously optimistic about this, but the scientist in me says, well, it's a very small study, it's 10 weeks, there's no control arm, you know, how much stock do we put in this? So we decided we would do the next best step, which is scientifically, we're doing a randomized controlled trial. And it's bigger, and we're looking at, more intense things, and it's longer. So we started phase 2. Folks enrolled in March, I believe. And the design of it is basically that people came in, they did their baseline visit, so we looked at all the tappies and the clappies and the wiggles and the walking and everything that you usually do when you go to the doctor's office for your Parkinson's. We asked questions about quality of life and depression and anxiety, and probably way too many questions. And then we partnered with some of our colleagues in physical therapy who have the GATE lab. And so people got hooked up to all the little sensors, and we watched sort of how they're walking and how they're turning, and really nuanced things about walking and balance and mobility so that we can hopefully detect if there is truly a change. And after that, we randomized people to either starting karate classes immediately for 6 months or being on the wait list for 6 months, and encouraging them to do whatever exercise they're usually doing or more, right? And then they will come back for their 6-month visit. We're coming up on that in the next month. And then all those folks who are on the wait list enter karate classes finally for the next 6 months. And the folks who are in the first 6 months, we hope, will choose to continue. And what we want to look at is how many of those folks choose to continue when it's sort of the real world test of, all right, now the study is no longer paying for the karate classes. If you were on your own, to do this, would you keep up with it? Right, and so we're looking at that, and then we'll measure folks at 12 months to see what has changed, what has stayed the same, what's gotten better, has anything gotten worse, right, and what does this actually mean? Because we want to know moving forward, is this, the same as other forms of exercise? Is it better? Is it worse? How is it different? And who is the right person, for this type of exercise? So with that, I think I have maybe 2 minutes left. I thought if you have questions for me, I'm happy to field them, but I thought it might be helpful to do a quick Q&A for 5 minutes, maybe with Sensei Salgado, Sensei Fonseca, and maybe 1 or 2 of the students. If people want to come up, if you want to ask them, they can answer far better than I can, probably. Thank you.
Should go here.
All right, any questions for karate instructors, for participants?
I think it's a good idea that they can talk with our students, and you can listen their experience. Please sit down before you listen.
Sorry, and I'm being told that we have a panel coming up, so we probably have like 2 minutes for questions, and then we'll do more questions.
Let me just say that I was one of the people that said, there's no way I can do this. So I was thinking, I just can't do it. I can't kick, I can't pivot. Well, now I can do all those things. So my message to you is don't give up. You can do a lot more than you think you can do. This exercise is really important, and it's been a great experience.
I would echo that and get the camaraderie of a support group with exercise. You're killing 2 birds with 1 stone.
Anybody have any questions? Isa. Definitely build up a sweat.
I find that it helps balance a lot more than cardio. I like the balance aspect, and I like the memory aspect, because you'll see later, I think, that you have to learn kata, which are patterns. So not only do you have to remember things, you have to tell your body to move in a pattern that you have to remember. So you got 2 things going. You got movement and memory.
And then many of us are compromised on one side, but in karate you're using both sides, so you're using both sides of the body. And as far as the kata, sometimes it's difficult to string together a series of movements. I couldn't line dance, but I can do a kata.
And if you do it wrong, there's no punishment. You do it wrong, there's a punishment. And if you do it wrong, there's no punishment.
No.
Enjoy.
No. Yeah,
about our tournament when you participate, our experience?
When we first started, we were asked to participate in a tournament, Fonseca Cup, and I have to tell you, it was pretty intimidating being with all these karate people that have taken karate for a long time. We thought it would be intimidating, but there's a lot of patience here. These senseis who are world class have infinite patience, and so I've been in, I think, 4 tournaments, and it's an opportunity to compete against other people who also have Parkinson's. So, thank you.
What's happening? So the question is, do we know what's going on when people are exercising in terms of dopamine function? And is there something we can see on MRI? Is there something we can see on DAT scan? So that could probably be a 2-hour-long talk. Unfortunately, there's a lot going on when people are exercising. If we somehow had you exercising, like doing sort of a, stationary bike while also in a functional MRI, we could probably see a lot going on. But we know that it seems like you're sort of enhancing dopamine production potentially in some ways and sort of helping to build synapses and increase sort of the neurotrophic growth factors, meaning that environment, sort of like all the juices that kind of help support brain health, those are sort of being enhanced by exercise, if that makes sense.
There's a question.
Is there any comparison to boxing and also to Tai Chi, which is supposed to help with balance, but it's not the same as this?
Exactly. So this is not the same as boxing. This is not the same as Tai Chi. The data that I've shown you is sort of the data that we have so far as we've just gotten started. So we do not have head-to-head comparison of karate versus boxing. I imagine this wonderful West Side Story sort of thing going on. We don't have that yet, but hopefully, down the line we can compare, because I do, we get asked that all the time, is which one is better? Which one would you like to do, right? Start with that one. And if you would like to alternate and do both, wonderful. So we don't have that yet, but stay tuned. And the Tai Chi absolutely has benefits, but doesn't tend to have the aerobic benefits. And we know, especially for the neuroprotective angle, that seems to come from the aerobic piece. So I think we'll probably take the rest of the questions at the next panel that's coming up. I'm sorry, guys.
Thank you.
Thank you all.
Thank you.
So in case you haven't noticed, the theme for this afternoon is exercise and keep moving. So today I would also like to welcome Kelly Martin and InspireFit to tell us a little bit about CrossFit training.
You want to get the slides up? Oh, okay.
Just go right here. You can just keep hitting right here.
Okay. How's everybody doing? Come on, guys, we can do better than that. We got the green light from the first doctor. I want everybody to say, when I say, how's everybody doing, I want everybody to say, we're doing great. Even if you're really not, just say it, okay? Let's shake the walls. How's everybody doing? One more time. How's everybody doing? One more time. Wait for it. How's everybody doing? Awesome. Well, it's very important not only to speak loudly, but also to enunciate the words and speak clearly and distinctly. And one of the things I like to do to start off is a tongue twister. Okay, we use this a lot in our groups. And what I want you to do is I want you to follow along and try to speak as articulately as you can and distinctly. So just follow along with me and repeat after me, okay? To sit in solemn silence. Wait, what is it again? That's it. All right, let's try it again. To sit in solemn silence. In a dull, dark dock. In a pestilential prison. With a lifelong lock. Awaiting the sensation of a short, sharp shot on a cheap and chippy chopper with a big black block. Nice work. Let's do it one more time a little faster. All right, here we go. To sit in solemn silence in a dull, dark dock in a pestilential prison with a lifelong lock, awaiting the sensation of a short, sharp shot on a cheap and chippy chopper with a big black block. Nice job, guys. Way to go. Awesome, awesome. So again, I'm Kelly Martin. This is my partner, Nancy Timko. We own Inspire Fitness, Inspire CrossFit, which is an exercise facility in Willowbrook, Illinois. We've been open a little over 2 years. It's a full-service CrossFit gym, which many of our Parkinson's athletes partake in. But we also have Parkinson's division exercise. And we currently train about... Yeah, it's an old slide. We currently train over 100 people with Parkinson's disease at every level and every stage. So we offer small group classes as well as private training, as well as we're a rock steady boxing facility as well. And it's kind of a mix what people choose. Some people do the rock steady in the small group. Some people want to dive a little bit deeper into the rabbit holes of their symptoms and choose the private training. We're also a 2-time grant recipient from the National Parkinson's Foundation. So thank you, Jessica, who's here from the National Parkinson's Foundation. We'll be kicking off an online training program here very shortly that I'll talk a little bit about at the end. So we're going to talk about today a few things. Okay, let's see. A few things. Hold on. So we're going to talk a little bit today about, and we're going to come back to about training on the bad days. And I don't think is it one more back? Yeah, one more back. Okay, there we go. So training on the bad days, and we all know what that is. Everybody here has had those bad days where, you know, the list of symptoms, anxious, can't move very well, all the symptoms are kind of magnified, and, you know, that's a big deal. But when it comes to exercise, we really need to, you know, to the best of our ability, work through these bad days. And that's very important, okay? It's very important to try to work through these bad days. And we're going to give you some exercises today for mobility, balance, strength, and stuff that you should be doing every day, along with your Fonseca karate, your rock steady boxing, your Tai Chi, all of that. So we're going to give that to you today. But first, I kind of want to go off script here. And this is going to be really fun. I want to recognize some people in the audience that exercise at our facility and kind of push them a little bit and have them demo what they do on a daily basis. So the first person I want to talk about is Ada Ron. And she came to us about a year and a half, 2 years? About 2 years ago, severely deconditioned. Sorry, Ada. Severely deconditioned. Really couldn't get into our facility without the help of a wheelchair. But she had just a fighting spirit, great will, and just put in the work and the time. Well, as it turns out, Ada and Omai, her partner, liked to go to the opera, and they had to stop doing that. They were season ticket holders. So we got her up and running. We got her back to the opera. And then one day, recently, they were going to see an opera that they really wanted to see. So they got to, you know, Chicago. I don't even know what it's called. What is it called, out of the Opera House? Or Lyric Opera, right. So they get to the parking garage and realize that Omai had forgotten her walker and her cane. So now she has nothing, right? So she has two choices, right? One, I can't do this. I'm going to go home. Or two, I've been training for this. I have the confidence in my ability, and let's do it. Let's just do it. Now, that's no small feat to come from Monroe Garage to walk up, cross Michigan Avenue. You only have a certain amount of seconds to get by, but they did it. And that was a big confidence builder for her, and they made it back as well, as you can see. So what I'm going to have Ada do is just give me, and I want to work with her a little bit, I want her to give me 10 hands-free chair squats. So I'm just going to go over there real quick. You guys just want to turn it. Come on, Ada. So, now, I'm not here to brag about my people, but I want everybody to take place in the same stuff that it's like every day. Yeah. Don't worry about it. Got it. Okay, I know. Don't worry about it.
You've been training for 2 years for that.
One. Three. Good. Come on. Up. 4. Keep going. Up. 5. You got this. Come on. Up. 6. Up. 7. Let's go. Up. 8. Come on. Up. 9. That's 1. Up. 10. Great job, Ada. So now we're going to move on to another gentleman that's been with us. His name is Steve Hart. He participates in our Rocksteady boxing classes and small group classes. Great athlete. Well, we're going to push him today. He's a little bit nervous about this. Steve is going to give us 20 burpees in a row. Okay? 20. Now, I don't think he's going to do it. So we're going to give it a shot. We're going to have to help him all the way down, all the way up. 20 times. 1, 2, 3. Got it. 4. 5. 6. 7. 8. 9. Gotta put in the work, buddy. Go halfway there. 11. Going, buddy. 12. Come on now. 13. Keep going. Got it. 14. Almost there. 15. Come on. 16. Got it. Come on. Got it. 17. 3 more, buddy. Come on. Woo, 11 mechanics been with us for about a year and a half. Well, big average cyclist, but cycle across. Not a huge fan of upper body work, so we're going to have him attempt 25 hand release push-ups in a row, no break. Hand release push-up. Oh, thank you. A hand release push-up is basically a push-up, so you lower yourself to the ground, release the hands from the ground, push yourself back up. So, Kev, let's do it. I know, we're going up. Trisha's got 30 to do. All right, Kev, let's do it. 25 hand release push-ups. You got this. No. Straight in a row. This is what we talk about. We all know exercise is good. Intense exercise is better. Let's go. Come on. 1, gotta help them count. 2, 3, 4, 5, 6, 7, 9, keep going. 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. 5 more, come on. 21, 22, come on. 23, 24, 25. Nice. I could do this all day. I really could. This is great. Nice job, buddy. Nice work. Nice work. Okay, we're almost wrapping this up. Okay, the next athlete we have is, her name is Trish O'Neill. She's she participates in the CrossFit that we have at the gym. She did the CrossFit Open and finished 21st in her age group worldwide. Okay, so she's a stud, right? So we're gonna.
Parkinson's people, that's everyone worldwide.
Yeah, everyone worldwide, everyone. So we're gonna have her do. I originally said 30 prisoner jump squats. That's okay. So I think I'm gonna up that number to 35. Prisoner jump squats, all the way down, big jump. Yeah. All right, let's go, Trish. We got to count them out. Big jumps. 1, 2, 3, 4, all the way down. 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35. Woo! Nice job. We have a bunch more athletes, but we don't have enough time. That was awesome, Trish. Way to go. I'm going to bring up Sean here. He does a rock steady, and I was going to bring the focus mitts, but I forgot. So, what? Yeah, we forgot the gloves, too. So I'm just going to have him run through just a couple punching progressions that we do with the focus mitts. Nice job, guys. Nice job. Nice job, Sean. Here we go. All right. I just had to show you. These are the same people that fight the same fight that you all do. You guys are doing a great job. It's just important to keep moving. So, we talked about the importance of training on the bad days and working through those, everything that you see in front of you. So, we know that the exercise, as we saw from Dr. Jory and all the doctors before, how important it is for the exercise to treat those symptoms, to retrain the brain. Balance and mobility, we're going to show you that today. So we're going to have my trusty colleague here, Nancy, run through, and here we have the top skills again. We're going to have you run through a mobility drill that you should be doing every morning when you wake up, every morning, okay? So first, might go. Okay, we're going to start with neck tilts, and we're just going to run down the joints. See, we're tilting the neck side to side, nice straight back.
Join in with me.
Yeah, you can join in. Neck tilts side to side. Good. And now from here, we're going to roll the shoulders back, nice and big. If you can't, some shoulder impingement issues, you can just shrug or try to roll them back. That's it. Now we're going to roll them forward. Okay?
Don't put the mic too close, they won't hear me crunching.
That's it. Now we're going to do the wrists. Let's everybody do the wrists. Make big little circles with the wrists. That's it. Now go the other way. Reverse the direction. Good. And now let's do fingers. See the fingers. Open them wide. That's it. Good. Now we're going to place our hands on our legs, and we're going to do what I call spine swirls. So we're going to pick a direction and swirl the spine around. This one feels really good, really good. So keep swirling that around as best you can. Try to get that good lean forward too if you can. That's important. Now we're going to reverse direction. Go the other way. That's it. Now we're going to come back to center, and we're going to go side to side. Hold the hands out, go side to side. Nice bend. Perfect. Guys look great out there. See a lot of moving bodies. That's good. Then from here, we're gonna move the knees in and out, kind of get them working. You can see, move the knees in and out. There you go. That's it. And figure about 30 seconds for each one of these exercises. And then we're going to come to center again. We're going to scoot back in the chair a little bit. We're going to extend the ankles and do some ankle circles. That's it. And then we're going to reverse that direction, go the other way. That's it. And then we're going to plant our feet back down. We're going to do some heel toe. Heel toe. Just rotate between heel toe. That's it. And then from here, we're going to go right into some knee extensions. Extend the knee. That's it. Again, we can pick 30 seconds of each of these. We can do 20 reps apiece, whatever you're feeling. Great way to start the morning, though. And then from here, we're going to do some high knees. That's it. And then you just finish with 3 deep breaths on your own count. 3 deep breaths. Yep. And breathe out. That's it. And good. All right. So one of the things we always talk about with Parkinson's is balance. So we're going to go ahead and show you a couple drills that you can do at home to avoid falls, improve mobility, and improve that confidence. So I'm going to have Nancy stand up, and I think you're probably better off going maybe against this wall. I don't think they can see you. So it's important if you're going to try these, especially these at home, that you do them against a wall or have a caregiver or significant other watch you, have a chair next to you so that you can grab onto it if you feel yourself going out of balance. So the first thing we're going to do is simply a 1-foot static hold. So we're going to raise a foot, hold that for 30 seconds, try to release our hand from the chair, hold that. So say we're at 30 seconds and
Your wall is behind you. If you're losing it, you have it right there.
Yep. And then we're going to switch feet. Okay. Switch feet, hold that. And it's okay. You don't have to stand there like a concrete statue. If your ankle is moving, that's good. You want that. Okay. You don't want to be so stiff that I'm falling. You want to have that active ankle that's kind of supporting you and making you balance on 1 foot. So now we're going to progress that up a little bit here. And we're going to go to a 1-foot static hold with arm presses. Now, if you can master this, you're doing really well. So you're on 1 foot, and you're simply pressing up. Okay? That gets too easy, put a couple soup cans in your hands or some dumbbells. Okay? Very good. Switch feet. You'll notice that one foot is a little bit harder than others. That's normal. And if you notice that, always try to do that one first. Okay? Good. So now we're going to do what's called a split stance. And for this one, it's good a lot of times with this one if you have two chairs like this. Or if you at least have one chair and somebody like there or that can catch you. So a split stance is just going to be putting one foot, so you got your left foot here, and then you're going to put your right heel on top of that one and hold that, okay? So we're going to hold that for 30 seconds. And then if we want to progress that up, we're going to add a clock tower. Good. We're going to hold that for 30 seconds. Then we're going to switch hands. Hold that. Good. Then we're going to switch feet. Let's go back to just that single static hold, no arms. Yep. And then let's do a clock tower on that side. And then switch. Awesome. Thank you, Nancy. So those are some balance stuff that you need to be doing every day at home. Very important. Strength. Ada demonstrated that for us today. We start with that basic squat, okay? So, one of the drills I like to do before we do this is go ahead and hold your feet out straight. Okay, now I just want you to slide down your legs. So you'll just roll your hands down your legs, try to stretch out that back. We want a mobile back when we try this. What we don't want to happen is we want to get out of the habit of this. Okay, where we're trying to get up and we're pushing up. We can't seem to get out of the chair. Okay? We need to lean forward, be able to lean forward. So this stretch is going to help with that. We need to be able to lean forward, get our nose over our toes. Or I like to say chin over the toes, push yourself away from the chair, pull in the knees. So why don't you give us a couple of those, Nancy? Good. Good. Then cross your legs or your arms over your chest like this. Right? Good. See how she's getting that good lean forward? She's leaning forward on the way up, but on the way down, she's also bending her hips. That puts her in a great position to go right into that next chair squat. Okay? Awesome. Thank you, Nancy. We talk about strength and balance. I want to show you one here that kind of accomplishes both. And I think what we'll do is we'll do it right here, Nancy. It's called a bird dog push-up. So we're going to start on the wall.
The counter in the kitchen is a great place to do that.
That's.
You can actually hang on to.
We'll start with the wall. If this is easy, we'll move down, okay? So go ahead. We're going to do a push-up on the wall. And then we're going to raise opposite arm, opposite leg. We're going to hold that for a second. Then we're going to return our foot down, do a push-up, raise opposite arm, opposite the other side. Okay? And then back down. Do another push-up. Let's do a few more on your own count. Just keep doing them. You want to make sure when you're doing them that you, after every bird dog, you're not walking your feet up to show them how you would walk your feet up. Then you do another push-up. Then you do this, and then you walk your foot up. Suddenly you're standing straight up. So you got to be cognizant to keep your feet back on every rep. Okay? Now, as Nancy was saying, if this gets easy or too easy, move to a countertop. If that gets too easy, move to a lower surface till you're able to do it in a regular push-up position and raise that opposite arm, opposite leg. That takes a lot of core strength and a lot of balance. But if you try it, keep doing it every day, you'll get there. The other one I want to talk about. Yeah. I got like 2 minutes? Oh, crap. Okay, yeah, we'll go quick. All right, so, yeah. So, let's go ahead and sit on the chair. The next one is mobility and strength. So we're going to try that. I call it knees over ball, but we're talking about putting our feet together, turning yourself to the side of the chair, then lifting up, placing your legs on the other side. Back down, get that forward lean, and over, okay? This exercise is great. It helps you get in and out of bed, get in and out of cars. So we want to become proficient at this. Even if you can't do it, or you can't get that high, keep trying, or your feet come apart, or this and that. Keep working at it. We have people that pick this up right away. We have people that takes months to get. Ada can do it. Everybody here can do it. But this is a great exercise. Okay, leg swings, real quick. So, leg swings is great. Grab a chair, swing the leg, great mobility drill. Okay, great. Do the other side. Yep, swinging the leg, just pick 20 reps per piece. Now we're just going to kind of, so what do we do with all this? So, we start with the warm-up. We're going to put it all together. So, Nancy, go ahead. Give me 10 chair squats. Okay? 10 chair squats. So, we're going to start with the squats. This is how we put all this together in a routine. Okay? 10 chair squats. Good. 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 And 10 knees over ball, so we'll just be here. You can place an object that you can move those knees over, so we'll do that 10 times. And we'll get your emails. If you want a written copy of this, we have this. So we'll do 10 of those. That's good, Nancy. Then we're going to hop up here, do 10 bird dog push-ups. Boom. And the less rest you have in between these exercises, the better, right? That improves your fitness. So this is stuff you can do at home. Great exercise. Yep, that's it. That's good. And then we would go right into the static balance, the 1 foot. Go right into that. I like to do balance after you've pre-exhausted your body a little bit. Makes it a little bit harder. So we'll do that. Then we'll go, right into our presses. Then we go right into our clock towers, split stance, boom. And then the other side, good. And then we finish with 20 leg swings apiece. Okay? So I just want, real quick, we have an online program that we're kicking off to help with the NPF. So just get in touch with us, give us your email, and we will include you on that. Thank you so much for having us today, and thank you, Lucy, for having us. All right, guys, take care. Thank you.
We're going to go into our question and answer period. So I'd like for the presenters to please take the stage. And any questions on any cards? Does anybody have any? Please raise them up. If not, we will go back hopefully. No questions? Something shows doing treadmill. If you have Parkinson's and you have balance problems, you don't do the treadmill, correct?
It depends. This is a phone line. I will repeat the question. So the question was that I showed the slide about the treadmill exercise, but if you have Parkinson's and balance problems or balance problems with your Parkinson's, you should not do treadmill exercise, right? And I think the answer depends on each individual person and what's going on and probably who's with you and the training on using the treadmill. Certainly there are folks, I know like at Shirley Ryan, former Rehab Institute, right? They get a lot of people up on a treadmill doing amazing things who, you know, shouldn't be on a treadmill, right? But, you know, with appropriate supervision and assistance, probably can get on a treadmill. But I think starting with, you know, having a trainer, having someone, a therapist there with you to say what's safe, what's not safe, and then building up. Good question.
No other questions?
Exercise both the balance or
That's a good question. So the question was, does exercise improve the tremor, the balance? Does it work equally? I think it depends a bit on each individual person. So certainly there are folks who feel symptomatically, they feel their balance is better, they feel their tremor is better while they're exercising and afterwards. I do have a few folks, and I think this is common, that some people feel sort of that endorphin rush and that adrenaline rush after exercising can make the tremor temporarily a little bit worse right after you exercise. If that happens to you, you are not doing anything wrong. It does not mean you are hurting yourself. It just means you've gotten a good endorphin rush, and that's okay. I don't think we have great data on any specific exercise that helps tremor specifically. In general, it's more the slowing down progression and helping people feel more flexible and move a little bit better. And then the balance-wise, so yoga and Tai Chi and Pilates have shown good improvements with balance. Those are the ones that have been studied the most as far as balance in PD. I hope that answers the question. All right. Yep. Lucy is telling me that is something that will be covered in one of the next sessions or at the end. It is too hot of a topic to cover just briefly in this setting. But if you have that question, so does everyone else in the room and everyone else in my clinic. Okay, so I'm being told that
Yeah, I've been a trainer for almost 30 years. I started off as a personal trainer, worked with my partner here, Nancy, and then I had a chance to get more on the medical exercise working out. So I got a job at Lieberman Center for Health and Rehabilitation in Skokie, and work with their wellness programs when Medicaid and Medicare was out. And for some reason, there was a large concentration of people with Parkinson's disease there. So I started forming these classes, and then they grew to capacity. Then I was approached by Dr. Danny Bega, a neurologist at Northwestern, the NPF. We designed a program, implemented it on the North Shore. But I'm not from there. Our gym is on the south side, so we had a chance to open up our own gym. I went to the NPF, and they gave us a grant to start up the same program on the south side because there's nothing, right? So that's kind of where it evolved from. Yeah, right. Yeah, with your help, Ada, for sure. Yes, yes. Just give us your email address and yeah.
Give us your name and address.
Yeah.
Email address.
Sorry, I got really off topic during that, so it kind of went really fast at the end. But yeah, we'll get all that you need, definitely. Sure.
all right. So with that, we will break a little bit. Question? So the question is there a preferred piece of exercise equipment that we would recommend for someone working out with PD at home? I will see.
Sure. Yeah. I mean, at our facility, we have rowing machines, we have treadmills, we have assault bikes, we have ski ergs. So there's really, I don't think there's any one that's better than the other. I think what you would have to look at is one that you can safely get on and get off, and one that has good mechanics. So a bike is always really good for that. It's a little bit easier on the joints. But I would probably start with a bike, and then one that, again, has a nice big seat that you feel comfortable and confident on, and then just work on kind of upping the intensity. So say if I do 10 minutes today, maybe I'll try 11 minutes tomorrow. Just try to get a little bit better every day. Or if I'm biking at a certain RPMs today, say I'm biking at 25 RPMs, maybe tomorrow I'm going to try to hit 35 RPMs and hold that for another 30 seconds. So for me, I'd probably start with the bike.
I would say I get asked by people a lot. They see like certain specific pieces of equipment advertised as this is the bike that you need for Parkinson's, or this is the thing. There is no the bike. There is no, the treadmill for Parkinson's. That's someone probably trying to sell you something. So if you find, a bike that works for you on Craigslist, that's probably the bike for you with Parkinson's, right? So just don't be taken in by some of the stuff that's out there. All right, probably last question, then we'll go to break.
Yeah, that's a great question. Definitely. We have a large, so the question was, do we see people from the Parkinson's program matriculating over to the regular karate program? And you can already see that the lines are getting blurred. The students who have come up through the 10-week pilot study that are now orange belts can do all of the curriculum that our adult students do in the other classes, and they're welcome to join any of those classes. So it's just about comfort level. Everyone can go to, they're welcome to go to any class. And right now, I think that you guys have stayed in the Kick Out PD program, but you can certainly, you're welcome to go to any of those other adult programs. We have a lot of kids in our academies. We have 5 locations in the North Shore and also one in Roscoe Village over here. But about 20% now are adults, and that adult population is growing. So we hope to piggyback off of the Parkinson's class and put together other programming like our Golden Dragons program, which we're launching. So that's our next class.
I'm going to make a quick announcement if I could. Anybody who upon registration didn't get a green raffle ticket, Jessica and Lauren have extras. So if you didn't get a raffle ticket, please stop by Jessica or Lauren, and we'll probably do the raffle for prizes as we get back from breaks in case anybody needs to leave early, then they don't miss out on the prizes.
Sorry, I was going to make one last comment before we head to break, and there will be another karate demo. But the one thing I wanted to say is I was remiss when I was speaking and introducing the group and saying that all of the folks that were up there are living with Parkinson's disease as a diagnosis that they themselves carry. So one of the people I will not shout out or point out, but I think that this is an amazing story and worth sharing. One of the folks who is up here as one of our students does not have a diagnosis of Parkinson's disease themselves, is a care partner of someone, and supported that person and went through all the 10 weeks of classes and then joined. So if you are a care partner, you need to be taking care of yourself. We know that exercise has great benefits outside of Parkinson's on anxiety and depression and strain and all of these things. You need to put the oxygen mask on yourself first before helping other people, right? And so if karate is the way for you to do that, awesome, whatever that is. But if you, join in, just because we're talking about all the exercise modalities for PD doesn't mean that this also shouldn't apply to care partners too. So, sorry, one last.
I heard a talk from Daniel Vega, and he talked about what he calls big exercise. Mm-hmm. Is there any data that shows how much that helps?
Sure. So the question was about big exercise. So that probably refers to large amplitude movements, and that stems from actually the Lee Silverman voice technique, which is a speech therapy that grew for people with Parkinson's and really is based on making very loud noises, right, and sort of using your diaphragm. And it was expanded to say, well, if that helps with the small voice and the quiet talking, this should help with large movements. Instead of having tiny, small, flexed posture and tiny little steps, what if we practice big, sweeping movements? And so a lot of the exercise modalities that are out there that have been shown to help incorporate big movements. So karate does, boxing does, Argentine tango has been studied, and it's lots of sweeping. I don't know it, right, clearly. So, but I hear that it involves lots of large movements like that, okay? And so that's what big movements are. There's no one specific big exercise. There are LSVT big physical therapy exercises that physical therapists can share with you. Sometimes you can download online. But in terms of different things, sort of the big, large amplitude principles are shared among a lot of these different exercise things. So there's no one. All right, time for a break. There's another karate demo. There's good, healthy snacks. Thank you all for keeping up your attention.
That's right.
There you go, or you can use the keyboard.
I think it's probably better. Just fine. How you doing? Good, man. Did you give a performance? Yeah. Burpees? I heard about it. Thank you. Thank you. All right. Can everyone hear me? Not too well? How about in the back? Can you hear me? Can you hear me now? All right. I'll try just to talk very loudly. I'm going to be talking about treatment of moderate to advanced Parkinson's disease. You're all coming in? Okay, people are coming in. Please come in. And we're going to talk a little bit about what is current therapy and what is more future therapy for when the symptoms get a little bit worse. And all of you know, unfortunately, that Parkinson's is a progressive disorder, so ultimately, just like with aging, we all know we're going to get there at some point where we have more difficulties. So how we're coping with that is a different story. So it's not just a sad story. I think I have enough in there that's a little bit uplifting, and that will give you some hope for the future as well. So the outline of the talk is as follows. We talk about symptoms of the advancing Parkinson's disease. We talk about what's called motor response complications. I need to give you a little bit of boring lecture as well. And then we talk a little bit more excitingly about treatment options. So what happens when Parkinson's advances a little bit? What happens to what we call the cardinal symptoms? Tremor, rigidity or stiffness, or slowness? Well, they just get a little bit worse over time. So we adjust our medications and on we go. But what is perhaps even more bothersome is that new motor symptoms develop. And of those I like to mention postural instability. That leads to balance impairment, which may lead to falls, and that's a severe cause of disability. People may start to have some start hesitation, or you have difficulties getting started, but once you go, you're pretty good until you have to turn, and the same thing may happen again. Ultimately, that results in more extensive freezing of gait, where you really are stuck to the floor when you want to enter the elevator, go through a doorway. Those are the points where people have gait freezing. These kind of things need more therapies, and we're working on that. On top of that, there are some non-motor symptoms that can develop, and some of these are very treatable, and some of them are not treatable yet. So this is a mixed bag of good news and bad news. Depression and anxiety, for instance, are usually treatable. They're good medications. We want to be aggressive about treating it. It can happen early in the disease, but especially also later on. And our SSRIs, the medications such as Prozac and Lexapro and so on, they are actually very helpful. Psychosis means usually that people have hallucinations, seeing things that were not there. It doesn't happen in everyone, but it can happen over time, and it's usually related to the medications that we try to help you with. So at some point in time, what we see is that patients, as they go through their journey of Parkinson's disease, and when they get older, we may move back from giving you 3, 4 different medications to just giving you one, levodopa, which is the best bang for your buck in the long run. It's the most powerful one, and it causes side effects, but perhaps not as much as some of the other medications that we used earlier on. And then there's, what happens? There's autonomic dysfunction. With that, we mean constipation, urinary frequency, and there are some medications for that as well. And some people suffer from lightheadedness when they get up. Also usually treatable, but sometimes it's difficult to do that. So the blood pressure control is part of the autonomic nervous system, which is affected in Parkinson's disease. So when people stand up from a chair, there's not enough blood going to the brain, and people feel lightheaded. So we use artificial means to raise the blood pressure up, and that can be very successful. Fatigue. Almost everybody, probably in this room, has fatigue. Can I see by a show of hands who has fatigue? I'll raise 2 hands. Lots of fatigue for me as well.
So this is something that is very common in Parkinson's disease, and we don't have a good treatment for it. What I really want to talk about is the things that we can do, because we can do a lot of things, and that is especially in the realm of motor response complications. But for that, I need to get to the boring act first, which is explaining you a few terms which will make it easier for you to communicate with your doctor about what is bothering you. So first of all, levodopa, medication that many people take. We know it improves disability, quality of life, longevity. It is a rational therapy because it's the precursor of dopamine, which is not made in large enough quantities in the brain of a Parkinson patient. So give the precursor, in the brain it gets converted to the dopamine, and voila, you can have close to a miracle response, or at least a partial good response. It's been the gold standard for over 50 years now. It came out in 1967. And nothing is better because it's such a rational therapy. But what happens over time? Normally you start therapy with 1 pill or half a pill 3 times a day. And even if you miss the middle dose, you don't notice any difference. But as time goes by, as years go by, the response to each dose of medication starts to change, and it lasts a little bit shorter, and you get periods where you're less mobile and periods where you're more mobile. And that is what I want to talk about. And patients will describe these episodes as they're feeling good versus bad, or they will say, I'm mobile or immobile, or they will say, I'm steady versus shaky. But we like to talk, as doctors, with you about on versus off. And it's good to have the same terminology. On means medications are working, I'm doing well. Off means the medications are not working, and I'm doing poorly. So these terms you will hear consistently in our clinic, and when you speak on the phone, it's good to talk in these terms. And then the second part, it's not just the fluctuations, the ups and downs, but what also happens is that people can develop involuntary movements called dyskinesias. Michael J. Fox is always a good example because everybody has seen some of the wiggling movements that can occur. And those also happen after prolonged use of levodopa. But we have treatments for that as well. So here, you see a tremor predominant patient. A little bit of freezing here, and she gets close to the chair. Right there, a little hesitation. And then I do the pull test where I pull people back and see how they respond. Usually it's my finger is your fingers. That's your nose. Bottom line, very slow. We call that the akinetic rigid type, where people don't have tremor, but are severely slowed. And you see this gentleman has a hard time getting up. 2 people need to help him. Sorry for the noise. And if you have 2 people, there's a good way, yeah. Could you turn the volume off? I don't want to touch any technology. If you have 2 people, you can actually rock a person back and forth and kind of make the foot come off the floor and use gravity to have the foot come forward. And this is what we had to do in this particular patient. So here we do the pull test as well. I will explain it to this patient. He's standing, you see this to posture. And the reason I'm showing you this is that I also will show you the picture after he is taking levodopa. So he's standing okay, but then me in my younger years, I'm much nicer now. I'm going to pull him back. He has no response. So this is scary. And I try to put him back, but then it's hard to actually have him stand. But there's good news, there's levodopa. Look at this man now, same guy. Just a few hours later, levodopa has taken effect. He's quick, he looks up in the camera, or at least at the finger. And he's really doing well. There he goes, getting up by himself. walking with arm swing. It's a nice white sock here on the left-hand side, holding his pants up. And I have a hard time actually catching up with him with the IV. And look at this, even his balance is better. Pulling him back, and it's not perfect, but it's really good. I like it so much, I do it one more time. Good, so that is, oh, sorry, that was a little bit too fast. But that was the woman we saw earlier, again doing great on levodopa, but she has a little bit more of the dyskinesia. And usually that doesn't bother a patient very much. It bothers maybe other people, but patients often don't realize that they have a little bit of movements, and they feel good because they're not off. The medication is working, and they can be mobile. All right, so together these fluctuations and dyskinesias are called motor response complications. So a little bit of terminology, not too much. We talk about wearing off. What does it mean? That means that you give a dose of medication, and instead of it working until the next dose, it wears off before you get to the next dose. So shortening of the response to an individual dose. If that gets worse and becomes unpredictable and more acute, then we talk about on-off fluctuations. On is good, off is bad. And that can be like a light switch. Delayed on means, normally, doctor, my pills kick in half an hour, but sometimes it takes 2 hours. That's delayed on. Dose failures means it doesn't kick in at all. Few more terms, dyskinesias, several types on the right-hand side. Off-period dystonia means when the medications are not working. People can have toe curling, foot turning in, and dystonia, cramping, abnormal postures in other areas as well, as we will see. Then people can get peak dose dyskinesia, meaning when the levels are high, they move a little bit. You don't need to remember this. Square wave dyskinesia, meaning if you want to have a response of levodopa, unfortunately, you always have some dyskinesia. Throughout the response to levodopa, to that particular dose, you will be dyskinetic until it stops working. Then you're off and the dyskinesias are gone. Next pill kicks in and you become dyskinetic again. We call that square wave because it's there all the time. And the last one is really complicated, but this is a smart group, so I'll mention it, diphasic dyskinesia. Some of you may have this, and it's always good to think, when do these symptoms occur in my levodopa cycle from dose to dose? So some people have bad dyskinesias in the beginning, just 10 minutes after they take the pills, and at the end, just before they do for the next dose. That is called biphasic or diphasic dyskinesia. The treatment is slightly different, so you want to tell your doctors about that when you think that's what's happening. So wearing off here in schematic, normally 3 times a day you take the dose, at 7 in the morning, at 12 and at 5, let's say, and the level of levodopa goes down, and then it goes back up with the next dose, but your clinical symptoms in pink actually are pretty smooth. This is how it should be and it should stay, but over time you get this next picture where you start noticing before the next dose is due that your symptoms start to return. If it gets a little bit worse and now you're taking levodopa every 2 hours, you will see that your clinical symptoms in pink start to really mirror the levels of levodopa in your bloodstream and in your brain. So those are called on-offs. Dose failure, pretty clear. That dose at 9 a.m. never really kicked in for some reason. Maybe you had a heavy breakfast. Maybe just some nice sausages and some scrambled eggs, and the pill is just sitting in between the two of them. So that can happen. The dose doesn't kick in, and for 3 hours, this patient is probably going to be what we call off. Okay, so you get the terms. Off-period dystonia happens when the levodopa levels are low, such as in the morning, early morning dystonia, before you take medication. But also at the end of each dose, there can be the toe curling and the foot inversion and some other symptoms of dystonia. So for that, you would take medication and it would get better. Here you see a good patient, I was going to say a good friend of mine, but patients become kind of friends over time, who has, many years ago, he had deep brain stimulation, and this was an evaluation for that, and we asked him to be 12 hours without his medication. He could only do it for 6 hours because he was so uncomfortable. You can see he has mouth opening dystonia, foot inversion, arms are dystonic, and then when he takes his medication, he has a difficult time walking. When he takes his medication, perfect. Levodopa is sitting there, he's perfectly comfortable. That off-period dystonia got better. He has a little dyskinesia in his gait, but he feels great. So we're going to skip these. And I just want to show you a regular peak dose dyskinesia. So when this gentleman takes his medication, he turns on. He has a little bit of good time without too much movement, and then when the level in the blood reaches a high level, he gets a little bit too much movement. But he feels good nonetheless. Now, how do we treat those? And this is the more upbeat part, because we have good treatments, and the treatments are getting better. How do we treat this with conventional medication? So think about those fluctuations first, the ups and downs. What would you suggest we do? Would you make a suggestion? What can we do if we have ups and downs? Yeah, you seem like doctor type to me. Well, perfect, higher dose. I don't know how you figured it out, but it's the first one on the screen. It's brilliant. So yeah, if you give a slightly higher dose, then the medication will kick in quicker. It will last a little bit longer. We try not to give too high of a dose, right? Because ultimately, the more you take, the more side effects you will get. But I will ask a patient, so how long does it take for your dose to kick in? And if they say an hour or more, I say that's not enough. It needs to kick in between half an hour and an hour. And if that doesn't do it, or if it doesn't kick in at all, we need to increase the individual dose at that particular time. Now, what if you tell me, well, doctor, it kicks in, but it doesn't last me long enough to the next dose? What would you do then? Right, give it more often. So you decrease the intervals, and instead of every 4 hours, maybe you give it every 3 hours. If that doesn't work, you can use a medication called Rytary, which is an extended release capsule, and for some people that works, where you don't have to give it that more frequently, but it's a long-acting formula. Like in the old days, we used Sinemet CR, sometimes we still do. This works a little bit better, I believe, than the CR. So that's a good option. And then we can use liquid levodopa. For those of you who are able to take medication every hour. It's not for everyone, but if you can be disciplined and take something every hour, you can just give the right amount. And why liquid? Because a pill is either half a pill, a whole pill, 3/4 is impossible to do. With the liquid levodopa, you can give 56 mLs if you measure it out. I can give you the recipe later. And then you can give just enough that it works for about an hour. And because you give such a low amount, you can get less dyskinesia. So people that fluctuate with dyskinesia like this on pills, with this liquid trick, you can make them fluctuate a little bit more like this. Okay? Make sure that you redistribute the protein and levodopa compete for absorption in the gut wall to the bloodstream. So if you have heavy food, then your pill will probably not kick in. So maybe you need to take a little bit more at a time, or take your pills an hour before you start eating. Make sure other medications are optimized. What are the other medications? Dopamine agonists, Mirapex, Requip, and Nupro. They all have other genetic names too, but I think this is generic names, but I think this is how you know them. COMT inhibitors, entacapone or Comtan. MAOB inhibitors, selegiline, razegiline, and amantadine. But how good are these drugs? So these are medications that have been tested together with levodopa to fill up these periods of off time, to get you go through the day without as much off time. But this is how good they are. The agonists, the MAOB inhibitors, and the COMT inhibitors. Look at that column, the off-hour reduction. So how many hours less bad time you have, and it's less than 2 hours. This is just not doing the trick. So people still, with these medications, have a lot of off time. So we need something better, and that's where we get to the interventional therapies. This is where you get excited, okay? So what kind of interventional therapies are there? Well, there are quite a few, and some of them may be helpful for some of you, and some of them maybe not. So I've divided them in injection therapies, inhalation therapy, infusion therapy, and surgical therapies. Let's start with the injection therapy. This is a Penject system here. There's a little container, a glass container with medication called apomorphine. It has nothing to do with morphine. And when you inject that, within 5 minutes, you can turn on. You can get a on state, a good state. So if you have a gap in between two levodopa doses, you can get a quick relief with this medication that is just as effective as levodopa. It only lasts for about an hour, but it's good to fill up a gap, and it's good to get in the morning and get going in the morning. This is how you inject yourself, in your leg or in your stomach. And on the right-hand side, you can see our gentleman from earlier who really could benefit from an injection at that time. And in 5 minutes, he would be just as good as what I showed you after he had taken his levodopa. Botulinum toxin, just so that you can tell your friends that you had Botox injections. We do that, actually. So what do we do it for? For these dystonic feet that you see here. And a lot of people have this upgoing toe and the curling of the toes, and we inject that with botulinum toxin. On the right-hand side, you see our patient here, and if I move the video over a little bit, where's my cursor? You'll see her dystonic foot. And so this person would benefit greatly from botulinum toxin injections. We use it also for eyelid opening apraxia. On the top two panels, you see blepharospasm is slightly different before and after botulinum toxin injection. We do the same thing in our patients who have difficulty with eye closing or just falling closed on them and not being able to open them up voluntarily. Many patients actually have that. So we inject them with a tiny little bit. It looks scary. The needle is very small. And so far, we haven't really punctured any eyeballs yet. So this works for people to some degree. Botox also is used for too much saliva. So if you have drooling, you can inject the parotid gland right there. Oops, sorry. Right here, and the submandibular gland is right here, and that is a very good treatment for drooling. So there is stuff that we can do for symptoms that you might not consider the most important ones, but they are important, and we do what we can do. So if we can help you with that, tell your doctor. Inhalation therapy, you've heard about it. This is the new one called Inbrija. That's levodopa, comes in an inhaler. It kind of does what that apomorphine injection does, except for it's not quite as quickly. The injection goes through the skin, and from there, it gets quickly absorbed. This goes through the lungs and gets also quickly, maybe in 15 minutes, gives you a benefit. So that's a relatively new one, came out this year. Now, let's go to the infusion therapies. This one, please remember, this one is not on the market yet. We've studied this with some of you that were very helpful in our studies, and they've benefited from it. But this will probably be out in the next year or two, and it's that powerful medication that comes in a very small pump and is infused in your skin continuously. And does it work? Well, let's go to this. Actually, this slide is probably the best one. So let's look at the daily off time. That's the easiest one to look at, daily off time. How many hours of bed time? Before apomorphine was started in the infusion therapy, people had 6.6 hours of bed time. After therapy, it was 5 hours less, so better. That is some big improvement, not these pills with 2 hours or less improvement. So this is a good therapy. And if you look at all the studies that have come out, open label studies, as we say, but if you look at the review here, there's about a 60% decrease in off time combined in all these studies. Next one is approved. This is the carbidopa-levodopa intestinal gel infusion, or Duopa by its brand name. And people don't like that because there's a tube and there's a pump, but it really works well. It's levodopa. You start it in the morning. It stays on at a set rate. You don't have to take your pills 6 times a day and think about it. And at the end of the day, you switch the pump off and you go to bed. So yes, you have a PEG tube. That's placed by the gastroenterologist with a scope. Takes about half an hour. You're sedated. You don't notice that you wake up and goes, hey, there's a little tube sitting out of my stomach. A lot of people get feeding tubes, so this is a routine procedure. But this is not for feeding. This is for the medication that is in that reservoir here on top. And this is the actual pump. You carry that, and they make a nice vest, and they have a carrying case and so on. And it's a very nice therapy. If you ask patients, how they feel. This is about 80 patients or 75 patients in a French study. And they asked patients and caregiver about how is your quality of life after we started this? How is your autonomy? How is your clinical improvement overall? You get the best answers from the patients and the caregivers. And they say greatly improved or moderately improved in the great majority of patients for quality of life, autonomy, and clinical global improvement. So I think this is a good therapy. We can skip this one. Okay, moving back, the Duopa I just showed you is approved, and now we have something that is going to be studied in our clinic and in multiple other clinics all over the world in a trial. So if you're interested in doing studies, this might be something for those people that fluctuate. This is the Neuroderm subcutaneous infusion of levodopa. Neuroderm is a company from Israel, and they came out with this slight change in the molecule so that it actually does go through the skin, because regular levodopa doesn't really go through the skin. Their formulation, very secret, does get absorbed to adequate levels to give you a good benefit. And it can either be a patch pump there or a pump on the right-hand side that's attached to your belt, slightly different one. Or, if you want to deliver more, you can have a double lumen pump and syringe to infuse more medication. And with that, you can actually get very good concentrations in the bloodstream. And that doesn't mean much to you, 1,800 nanograms per ml, but that is kind of where you want to be. It's probably sufficient to keep you on throughout the day. So another way to administer levodopa continuously, and that is the trick. So to prevent these ups and downs, give the drug continuously. And the least invasive, the better. So we are very excited about this trial, and I'm looking forward to your responses to that. So let's end with the surgical therapies. There are two that I want to discuss. One is deep brain stimulation. And you've heard a lot, and you've seen a lot, and you've seen the before and after videos, and you know people that have had deep brain stimulation. Some of them are actually in this room. So I won't stand still too much. Just I want to tell you first what the overall experience is. This is an older study from 2006, but I think it's useful. It compares in a controlled fashion patients who undergo surgery here and patients who are at the same time randomized to receiving medication for that first 6 months period. And after 6 months, they compared the two groups, baseline, 6 months later, for both surgical and medically treated group. And these are the results. So first, sleep. Got a little bit better in the surgical group from 7.7 hours to 8.4. That was significant. And that's our experience, that people do sleep a little bit better. In the medical group, there was no change. The next one, state of immobility, from 6.2 hours, off state, immobile state, to 2 hours. Big reduction, 4.2 hours. In the medical group, it didn't change. The in-between state, we usually don't talk about in-between states, but that stayed the same in both groups. But if you look at the mobile state without bothersome dyskinesia, that went up from 3 hours to 7.6 hours per day, and it got a little bit worse in the medical group. So this is what we can expect from our surgery for the appropriate candidates. Everybody knows the equipment. There's a battery here. There's an extension cord that hooks up to the brain lead that sits in the brain in the area that we want to stimulate. Here you see the classic batteries that consist of a battery and as well as electronics that provide the pulses. And the classic lead that we've been using is this lead, the Medtronic lead, and it has 4 rings. The total length from this one to this one is where the electricity can come out, and it's not like this, but if I make it real, you cannot see it in the back, but it's 7.5 millimeters, like this. So it's very close together, so we can very precisely determine where the best spot is in the brain. But we go one step better now, and that's what I want to share with you. The newer leads are depicted here, and just look at this big lead here. So you see there's still 4 contacts, but the middle 2 contacts are now divided. Each ring is divided in 3 segments. And we can activate each segment individual, which means that to some extent we can steer the current. After the lead is already implanted, away from side effects, let's say, and towards the area where you get the best improvement. So this is called directional stimulation. It's new, and we use this now all the time. And I think it's very important improvement to reduce side effects of deep brain stimulation. I can't help to show you this. So this is what happens when you stimulate a ring electrode. You see at the bottom here, this is in egg white. It's a laboratory test. You send a lot of current through that lead, and the egg white starts to coagulate around that circle, right? But now, look at what happens here. We only send current through that one segment, and only the egg white around that one segment starts to coagulate. So this implies that the current is coming out in one direction. So this is very exciting. And brain stimulation is maybe not for everybody. Usually we don't like people to be too old. The later 70s is getting a little bit too old. It is invasive. You need to drill some holes and so on. But up to 72, 73, I think we still, when people are otherwise healthy, we still do deep brain stimulation in appropriate patients. There's something new now that I'm very excited about, and we'll show you a few slides of what's called MRI-guided focused ultrasound. So there was actually a trial already in essential tremor. That's a different type of tremor, a different disease, where tremor is the only symptom. And the trial was published and got a lot of attention. And what is the technology? Well, you can make a lesion in the brain with ultrasound waves without entering the brain. In the past, we made lesions, pallidotomy, thalamotomy, as of the 50s already, 1950s onward. But that was going through the brain and heating up the tip of the probe or making a radio frequency lesion. And it was never very accurate, and you couldn't do it on two sides. This is a new way of making a lesion without going through the brain, by focusing ultrasound waves. The energy from ultrasound beams can heat up the tissue from the outside. In the old days, this is not a new idea. It's been around for maybe 50 years. But in the old days, ultrasound waves could only work if you had what's called an acoustic window. You need to do a craniotomy, taking part of the bone out, and then the sound waves could penetrate. Now they have newer transducers that are fancier, and that you don't need to open the skull at all. So I should tell you before I go there, you still get a stereotactic frame, just like with DBS. A frame is attached to your head, because with that frame on, we can determine the coordinates in the brain where we want to be. So with that frame on, you get MRI pictures. This is an MRI scanner. And on the MRI, we can see where we want to be, and it has coordinates relative to that frame. And that frame is coupled with that transducer for ultrasound, that machine for the ultrasound. On top of that, we can measure the temperature with the MRI. It's called MR thermography or thermometry. Why is that important? Because what we do with this machine, we slowly increase the temperature to about 40 degrees centigrade, maybe 45. That creates a temporary lesion. We make sure that the tremor goes away and that there are no side effects. And if that's the case, then we increase the temperature to 60 degrees, and that makes a permanent lesion. If we feel we're not in the right area, we refocus the sound waves to a different area and then make the lesion. On top of that, there will be, of course, a neurologist in the room who's testing patients continuously. So this is a safe method of operating. So here you see the brain, and here you see from a distance maybe the green circle, and in that circle is the target right there. And the next screen is that you see where the beams are coming from, and they all focus together on this area. So you can imagine that in the periphery here, on the outside, there's just a ray here and a ray there. That doesn't do anything to the brain. But when they all come together in this area, that's where the energy is delivered, heats up the tissue, and that's where you get your benefit. So this is from that essential tremor study. You see that the results, each blue bar represents one patient. vary a lot, from 85% reduction in tremor to, on this side, 0 reduction in tremor. On average, there was a 47% reduction. With DBS, we get better improvements, but mind you, these are people that probably don't qualify for DBS. So it's promising. Also, when they have a new technique, it can only be improved upon if there's a learning curve over time. So I think the efficacy will go up from here. Now comes the Parkinson side to this. Already there was a paper looking at different types of tremor. I'd like to draw your attention to the Parkinson's disease here, number 3. Starts with a lot of tremor here when drawing spirals. And then 1 week after that ultrasound lesion, that's a lot better. And if you look 1 month later here, it's still a lot better, but it's not as good as after 1 week. And again, this is a new technique. So I bet that these people made a very careful, small lesion, and that they need to be a little bit bigger. The same thing is in this last slide that I'm going to show you. This is another study. This is not approved yet. It's another study that shows what can be done in the future for Parkinson's disease. And this is not just for Parkinson's tremor, but it is for all the symptoms of Parkinson's disease. And you see again the improvement on the vertical scale in the first 4 patients. It's very minimal. And then they figured out why that was. They targeted a different area of fibers, not so much of cell bodies. And it turns out you need more ultrasound energy. So then after patient 4, they said, let's do that. Make more of these sonications to make the lesion more slightly larger. And then subsequently, patients did really better, not just for tremor, but for all their Parkinson's symptoms. So I think this will, in the future, this is not done yet, in the future will be a very good option. Right now, it's approved for people with either essential tremor or Parkinson's tremor. Okay? In the future, we may go to another area that also addresses other parts of Parkinson's disease. So I'm very excited. Rush will get this. It's very hard, but Rush will be the only one in the state of Illinois that will get this machine. And we're excited to start this maybe in early 2020. It will be placed in our Oak Brook facility. And I just want to show you what I call the Rush Interventional Therapies team. Jessica Carl, here on the top, is the PA that is the main programmer of all my DBS patients, and she's also involved in all the infusion studies and the infusional clinical treatment. Dr. Paul, you will know, is organizing this great symposium. He is doing the same thing what I'm doing, interventional therapies, and Diana is basically our link to all the patients. She's wonderful MA that helps us and lets nothing fall through the cracks. We have 2 neuropsychologists that test most of our patients before and after surgeries. Dr. Sani Sepper is our neurosurgeon and has been for the last 5 years. So we do these deep brain stimulations together. Dr. Lasurdo in the middle here is our GI doctor who is absolutely great. All patients love him. He is placing those tubes with the scope, and these are the collaborators of Dr. Sani and Dr. Lasurdo. So finally, I have some time for questions or not? No. At the end? Okay, hold your questions, but please remember them, and I'll be happy to answer them later. Thank you.
Thank you. So I'm hoping everyone this time is taking the opportunity to write their questions down on the index cards. And I would like to introduce our last speaker of the day. He really doesn't need an introduction, but Dr. Getz, welcome.
Thank you. Let's see, we're going to go. Okay. I got it.
To the right.
Yep. Okay. Good. So I'm going to close the afternoon, and we're going to have some questions and answers. But I thought that we would have also a session on just talking about what's coming up in the future and what are the opportunities right now in terms of advancing the science and the treatment. I have 3 different categories to talk about. Treatments that are newly available. Some of this will be review, but it's good to reinforce things. Some of them you've heard about already, and then I'll kind of close with them. Treatments that we are studying now, and some of you are in research protocols and therefore are joining us in advancing the science and determining whether a new treatment is effective for our patients in the larger sense, so that will be for the future. And then there's some new concepts that I want us to be aware of, that we watch the progress of this in the coming year. So that's those are the three general areas that I want to talk about. So new treatments that are already available, newly available. Well, in the last several months and even overlapping into last year, we have a new monoamine oxidase type B inhibitor called safinamide. There are two older drugs in this category of MAOB inhibition. There's rasagiline. Some of you may be taking rasagiline. There's also selegiline. But safinamide is new, and it is available to prolong the effect of the Sinemet that you may be taking, or levodopa, to affect and improve motor fluctuations. It is new. It's expensive. But in America, we kind of like what's new, so there's been a great interest in this drug. And there doesn't seem to be any specific advantage of this drug over others, although I've talked with European colleagues with many years of experience, and they feel that there may be, even though it's not approved for this, there may be some improvement in dyskinesia. And one would not expect dyskinesia to improve with selegiline or rasagiline. So if that's the case, it's still too new in America for us to really be able to study that, but that's something to at least consider. Pimavanserin is an agent that is specifically approved for treating hallucinations. This is my area of particular interest in research, and we have not had a drug that the FDA approved specifically for the hallucinations in Parkinson's disease. So this, for me, is a great step forward, and there are other agents that we are currently studying that I'll bring up in just a few minutes. There are new formulations of older drugs that have been on the market for years, but now are reformulated to be perhaps a little bit more convenient or more effective. Specifically, there's long-acting amantadine. Amantadine is a drug from the early part of the history of treating Parkinson's disease, but it's always been a drug that had to be taken multiple times during the day in most cases. Now there are two formulations, one that's taken at night and is approved for dyskinesia, one that's taken in the morning and is approved for improving the duration of effect of the Parkinsonism. So these are agents that could be discussed with your doctor. Of course, anything new is going to be more expensive than the older drug of the amantadine. There's also, and Dr. Verhagen already spoke of this, of the new inhalation levodopa. So many patients, they get good response from their levodopa, but it just doesn't last from dose to dose. And so in many patients, they don't know which dose is going to fail them, which dose is going to be short on action. And it doesn't allow then for me to prescribe, we'll take an extra half tab at this dose to prevent it, because every day is a little bit different. This type of inhalation treatment allows one to take the puff when you need it. And so you have to be organized. You have to have it kind of loaded so that when you start to go down, you take this little inhalation, it kicks in quickly and just gets you to the next dose. It doesn't treat the Parkinson by itself. It rescues you to get you to your next dose to treat the Parkinson's. It can be used up to 5 times a day. It does have a side effect that, because it oxidizes, has a chemical reaction with the lungs, it will blacken the nasal secretions and the saliva. And some people find that quite disturbing because it's black. I mean, it's not like a little gray. No, it's black. It's black. It's black. I mean, so you have to sort of know about this and say, could I live with this? Because it's not optional. It's going to happen. All right. So that just has to be, I think, to me, warning, and then you try it and see if it helps. The new approaches that are surgical or in the interventional realm, Dr. Verhagen has reviewed, so let's just reinforce them. The guided ultrasound is coming. It is FDA approved for the essential tremor, which is not the group here, but for patients with Parkinson's disease tremor, it is also approved. But it does destroy. All right, Dr. Verhagen said you get the guided, you get the stereotaxic equipment on it. They measure, they check, they verify, they measure. But once that button is pressed, you can't undo it. You can't turn down the voltage. It's done. It's just plain done. So you say, well, But at least that's easy. It's relatively easy, and the technology is quite advanced, but you don't have all the adjustments and arrangements and follow-up that is seen with the deep brain stimulation. So for people who can't travel, people who can't manage multiple adjustments, this does offer some hope, and we will soon have this, and as Leo said, it will be at the Oak Brook facility. It's not surgical, but it's still invasive. Right? That we should not be cavalier about. It's not a drug that you can stop. It's done. There's also interest, and there have been some newspaper articles about spinal stimulation. This is something we're going to be studying in the next year. And this is a spinal cord stimulator, and those of you who did science in college may have remembered the experiments there where cats are stimulated in their spinal cord, and then they start to walk, even though they're totally anesthetized, they can't feel, or they're in coma, right? And they walk because you've stimulated their spinal cord. And many patients with Parkinson's disease freeze. They simply can't walk. Their muscles work, but they cannot walk. And this spinal stimulator is aimed at forcing the nuclei in the spinal cord to start this marching, so you can march. And it's kind of a little bit, say, my goodness, I'm kind of like the Tin Woodsman, that I'll just start walking all by myself. Well, you're not a robot. But this stimulator would induce automatic walking. Something to be studied. The Europeans have studied this more than the Americans. We still have to sort of see and find our own way with this, because I don't want people walking, without any control over where they're going. So there's a lot to be studied in here, but it's quite exciting, and it's a completely different area. It's working the spinal cord, even though the disease of Parkinson's disease is up in the brain. In terms of treatments in research today, what are we studying with our patients up in the suite? Well, in early Parkinson's disease, we are studying antibodies against synuclein. Synuclein is the protein that when it coagulates or aggregates in the brain, it damages the cells. And the fragments of this synuclein, when they get out of a cell that has died and now is circulating around in the brain, that little fragment of synuclein can get into the next cell and can spread the disease. We know all about this. So what we would like to do is not allow any spread and stop those fragments from ever being able to get into the next cell. And that's where you would think a vaccine should do this. We should be clever enough to do this. And so we have developed antibodies that are now infusions. But if this works, and some of our patients are in this program, if this works, then we would make a much more concentrated form and actually be able to potentially immunize patients with Parkinson's disease today, all of you, so the disease would get no worse. Imagine, because most of my patients say, I don't like what I have, but I could live with this. But I live with the burden of fear about the future. But if we could immunize everybody and say, worry not, we'll treat what you have, but it can't get any worse, that's an enormous gift of science. So we're thinking, we're in this. We have many patients who are in this program, and we will be advancing this program with other agents because there's more than one antibody that could do this. In terms of new treatments for the Parkinson's itself, there's been a presentation about karate and actually what that does in terms of helping patients in terms of their motor control and their balance. There are at-home care strategies that Dr. Fleischer is examining. There's a telemedicine whole program to help patients who cannot come to the medical center. So there are ways that we are outreaching to attend to patients and their needs, even though they might not necessarily be medications. In terms of special problems that patients have, again, I go back to my interest, hallucinations. We are studying a new agent. If there are people in the group here or you know people who are actively having hallucinations, I'm interested in trying to see whether I can recruit your participation to study a new agent that is particularly honed, is really kind of chemically sculpted, that should work in our hallucinators. And I want to see if it works. And so it's got a name. It has a number and a code, but doesn't even have a name because we're way too early. But if there are people who would like to test this with me, I have openings. There's also a new agent that will be looking for cognitive problems or memory problems. So there's always this active area. And these are all aspects of Parkinson's disease, but not necessarily tremor, slowness, stiffness, balance problems. So the ancillary aspects of the behavior of Parkinson's. There's an issue of non-motor fluctuations. We talked about motor fluctuations where the drug might not last. But there are patients in my practice who, as the medicine is no longer lasting from hour 3 to hour 4, and they still have to wait an hour, not only do they slow down and get more tremor, but a terrible sense of anxiety or doom or darkness descends on their brain. And we are interested in that. We want to treat that as well as the tremor and the slowness. And so Dr. Verhagen has a program specifically looking at this with the intestinal infusion. So there are a number of different kinds of programs looking at not only the motor, but also the non-motor aspects. What should we look for in the coming year? Well, in early Parkinson's disease, I told you about these antibodies, all right? Dr. Hall is leading those programs. We're thinking about neuroinflammation. There's a lot of talk in inflammation in general in medicine, but specifically in the brain. Inflammation in the brain is not a good thing in terms of healing and in terms of stability of chemicals. And Dr. Wittek has a whole program around neuroinflammation. And Dr. Compoliti is looking at new treatment agents that affect energy utilization. How do the subcomponents of the cells in the brain, how do they use the energy that they get? And are those under extra stress because of the Parkinson's disease? Can we relieve that stress? Those are for the early patients who are otherwise not medicated. New treatments for the Parkinson's disease itself. What's coming up? Well, Dr. Fleischer continues with her celebrated karate working, extending more geographically wide, and so going west, going south. Of course, the lake is the east, so we're not going to go there, but with this will be an expanded program. The at-home strategies likewise will be expanding. And Dr. Afshari has a whole program related to telemedicine and specifically doing physical therapy via telemedicine so that people can do exercise and be monitored from home with our supervision. The special problems, I alluded to the hallucinations, the fluctuations. Dr. Barton and Dr. Verhagen are looking at things. There's a new study that is completed now, but we're not quite sure what the FDA is going to do with it, of taking a medicine, the apomorphine that Dr. Verhagen alluded to, but now not as an injection, but instead just under your tongue. So if you start to go downhill, you put a little lozenge under your tongue, perk up, and it gets you to the next dose. These kinds of things are very exciting. There's an agent called accordion levodopa that we've been studying, and then the advanced surgical programs. Finally, there's an issue of gene therapy, of which we now understand that 10% of patients with Parkinson's disease, actually the disease itself is due to a genetic mutation. That's 1 out of 10, but it's still 1 out of 10. And those patients, we know what went wrong. We know exactly what chemical reaction is causing the Parkinson's disease, which is an extraordinary illumination, because if we know the chemical reaction, we should be able to design an agent that inhibits that chemical reaction. That's what chemical engineering is all about, and we're good at that. So now with the definition of some of these agents, and I give you the example of GBA, and we could talk about this at our leisure, but there are forms of Parkinson's disease where now the therapy is aimed specifically at the genetic abnormality. Not at dopamine, that's the final common pathway, but at the origin, the actual genetic abnormality. To me, that's enormously exciting and something that wasn't even conceivable in my residency training in my younger generation. So this is very much the next generation. Finally, let us remember that the way Parkinson's disease affects people and the disability and the quality of life, there are aspects that are universal, but there are other aspects that are cultural as well. And the way Parkinson's disease is handled in one country or one culture may be different, and there are also racial differences in terms of the genetic makeup. So we have to also be studying this. Dr. Bailey leads that effort in our program. So a wide variety of things for the future. Final, just what is research? Well, we ask in research a clinically pertinent question, a question we think is applicable to you, and we want to design a definitive study. And so we ask our patients, do they want to switch for this program and join a scientific adventure in which there's one goal, and that goal is report accurately. When I see my patients as a doctor and patient, our goal is you get better. But in a research project, it's report accurately. Most treatments have a placebo arm because most patients with Parkinson's disease improve in a clinical trial. It's because dopamine is activated when you anticipate, when you are encouraged, when you are expecting. All those behaviors augment dopamine, and therefore in a clinical trial where you don't know what you're going to receive, there's in fact an improvement in almost all patients, and that's the placebo effect. It's positive clinically, but it is not part of the treatment effect. Patients give their time, they expose themselves to an unproven treatment, but they do gain access to agents otherwise not available, and way much sooner than they would ever be available in the regular clinic. They need to come more often. They keep records. They report to us accurately. So to be a good research candidate, you cannot expect. You can hope, but you can't expect. To be a research candidate, I ask my patients, answer yes to the following questions. Do I want to get better? Of course you want to get better. Do I want to help others? Not everybody. You would wish you'd say yes, but not everybody really feels that. And you have to answer yes to both because you are helping others. So you speak to your doctor, you send your doctor a note in the MyChart, and we can find likely a program of interest to you. For those of you who follow the international advancement of science, I tell you that every year the International Parkinson and Movement Disorders Society has a Congress. It changes throughout the world. This year it is in Nice. It's next month. So your doctors, your faculty will be traveling to Europe for gathering for 1 week all the information about where we stand internationally with Parkinson's disease and research. They will be on the podium. They will be sharing our research from Rush. You are all a participant of that. And that's how we gain the encouragement and the dynamism to take this the next step into the next year. So that's where we stand. And I think, Lucy, I turn this back over to you. Thank you for your attention.
Thank you very much. Does anyone have any cards for questions and answers? We'll step up.
I'm going to have someone else come and pick up the questions and index cards, but I think Dr. Paul, Dr. Gatz, and all the speakers today would want me to bring out 3 important people today that I think have done a tremendous job with the workshop, with the symposium, and that is Lauren. Could you come out here, please? These are the faces that you guys do not get to see. Lauren, Lisa, come up here, please. And our fearless leader, Kimberly Parsa, could you please come up here? Thank you very much. And raise your hand for any questions and cards. Thank you. No. Well,
Are we ready?
We're going to come up. Yeah.
You can come up here.
Any other questions? Cards? Oh.
Let me start. Can I start? Please. Okay. I have a question about CBD oil and marijuana. So, and this is a very frequent question. The answer to this is we don't know. And the dilemma here is that the legislators have placed Parkinson's disease on the approved list for medical marijuana and products, but in Washington, marijuana is illegal. And in order to do a clinical study, we have to be registered in Washington. So until these two agencies get coordinated, we're really blocked from looking at any solid scientific study. But what I can tell you from my own patient experience is that patients who, and they're probably patients, I just saw colleagues, who have experience with this, and they could share, but what they have told me is that if they take what the marijuana repository or the dispensary officials give them and tell them, it's way too strong for Parkinson's disease because you're getting medicines that go into the brain already, and this is too strong. Patients feel dopey, patients can fall, and it's not a good activity for them. On the other hand, before we close this, if they dilute it, for instance, the oil seems to be the most popular amongst my patients, and they take their little dropper and then they put 10 extra little drops of olive oil, mix it up, they feel better. They feel more relaxed, they have less tremor, they sleep better, they have less aching. So I'm only sharing, but I remind you that every bottle is a completely different potency. There's no quality control. And so if you get a new bottle and you thought, I've just got it perfect, it's 2 drops to 4 drops or whatever you're going to do, you have to start all over. So it's a uncharted territory. We plan to study this, but we have to get permission to study it, and we have to have one source where we know the potency and the quality control. And that does not exist at the present time. Well, that's a different question, but it still hasn't been specifically studied. And the question was about anxiety. Yeah, how about using the marijuana or the CBD or the THC, whatever it's going to be, any of these products for the anxiety or depressive symptoms associated with Parkinson's disease. Again, these issues have not been extensively studied, and you have to remember that any dosing that would come from another condition is not applicable to Parkinson's disease because we are already exposing you for treating the motoric aspects of Parkinson's disease with agents that outside in the community are not being utilized. So it's a tricky business. My point, be cautious, and if you use it and you discover something, share it with your doctor because we haven't studied it. Leo?
Thank you. First, can you hear me? Wonderful. Thank you for sticking with us for such a long period of time. It's beautiful weather outside, and I was happy to see that my questions are questions that I can answer with just 1 or 2 words. The first question, dry skin. Is this a Parkinson's symptom? Yes, it can be, and there's a treatment for it. It's usually called seborrheic eczema, and your dermatologist can prescribe you some creams and oils that will be taking care of that. Next question, is it okay to get the shingles shots? Yes, it is okay. Is it okay to use cortisone? If that's indicated for whatever your doctor prescribes it, it's fine from a Parkinson point of view. Can you be too young for DBS? Well, I am biased. I think DBS is a good thing, so never too young for a good thing. But only if you have the symptoms that are going to be responding to DBS, and if we cannot treat it in a non-invasive manner. So in the other room, there were some videotapes of kids with dystonia that got deep brain stimulation. Generalized dystonia, terrible disorder, no good treatments. And we operate on these kids when they're maybe 10, 12 years old. So it can be done. But the most important part is, what do we want to treat? What are the symptoms that we want to get rid of? And can DBS do that? And that's part of what I do, evaluate patients for those particular questions. Can I do one other one? Botulinum toxin for lips sucking in. Worth a try. Lips are tough though, because you do a lot with your lips. Right? Can anybody name something that you do with your lips? Talk. I heard some kissing. There's a naughty table right there. Yeah. Eating, right? So there's a lot of things that you need very fine lip control, but it's worth a try. A little bit of Botox, very small amount, can help with that dystonia of the lips that can happen as a result of Parkinson's disease. Finally, difference between levodopa and carbidopa-levodopa. So levodopa is the active, really the active component. Levodopa is the precursor of dopamine. But if you give levodopa by itself, and that is how we started out in the 50s, you need huge amounts because it gets already converted into dopamine in the peripheral bloodstream, in your blood vessels, before it goes into the brain. And what does it do when you have dopamine running in your blood vessels? You get nauseated. The carbidopa prevents that conversion until the levodopa has made it up into the brain. The carbidopa cannot enter into the brain. It's just structurally not entering. So once the levodopa is in the brain, it gets converted to dopamine, which is exactly what you want, and you don't get nauseated when that happens. All right, so that's the difference. We give the carbidopa to prevent you from getting nauseated and to be able to get away with much lower doses of levodopa because it inhibits the conversion of levodopa into dopamine. I think that is all I have here. Oh, one question for Guion, maybe. Dr. Paul?
Sure, I'm right here.
We have a guest panelist, Dr. Paul. When is genetic testing recommended and how much does it cost?
Yeah, it's a great question. So I think at this point, we don't recommend genetic testing for clinical purposes because we don't have a treatment to offer you based on the genetic testing. However, as part of research, we can do genetic testing and for certain trials, clinical trials, just as Dr. Getz mentioned, for GBA and soon for another genetic form of Parkinson's called LRRK2, we can do some testing for that as part of the enrollment in a clinical trial. So if you're interested in these types of trials, you can ask us in clinic, ask your doctor in clinic, and we can point you in the right direction and do testing as part of the trial. You have to be cautious with things like 23andMe, which are things that you can get testing. I mean, the test results are accurate and valid, but just so you know, they test for two genes. They test for GBA and LRRK2. For GBA, there's over 300 variants. 23andMe tests for one of the 300. Okay, so for LRRK2, there are several variants, and 23andMe tests for one of them. So it's a nice price tag for $99 that you can get, those two variants tested for, but it's certainly not comprehensive. So if you're interested in learning more about your disease, I would urge you to discuss it with your neurologist, and then we can work with our genetics team, our genetic counselor, and point you in the right direction and discuss what are the benefits of getting the testing, what are the risks of getting the testing, because once you learn that information, you can't unknow it. So just because you can do it doesn't mean you should. So, but that time may come in the future. Okay.
I have a question that covers both the oral medicines and the Duodopa program, that doctors seem to emphasize that you take levodopa during the day but not at night. Please explain. The concept's not exclusively that we stop at night, but it is, the levodopa is a stimulant, and it can be associated with nightmares. When it's dark, people are at risk for developing hallucinations. So we tend to sort of cycle down at nighttime. If people are particularly stiff, then we may give the long-acting, the controlled release form of levodopa so that they get a low level that lasts several hours. But it is true that we tend to try to downplay the levodopa exposure during the night. Part of that is also because perhaps you're a little bit more sensitive the next day if you haven't been chronically exposed on just 24-hour basis to the same agent. Leo, you have a question?
A question for you?
No.
Oh. I was going to say the same thing because you mentioned Duopa.
Yeah.
So it's that infusion of levodopa. It's also approved by the FDA for 16 hours of wakefulness. And then suppose it's you turn it off at nighttime, and that's what we do. In Europe, where this has been on the market much longer, some people do take it throughout the night, perhaps at a reduced rate, because the idea is that if you don't have Parkinson's disease, you create less dopamine in your brain during nighttime as well. So we try to simulate the normal physiological condition. This says that a certain guy by the name of Dr. Verhagen mentioned that the MRI-guided focused ultrasound addresses more symptoms of Parkinson's disease. Which symptoms? So remember I said focused ultrasound is approved now for Parkinson's tremor. And that is in a specific part of the brain called the VIM, the VIM. Just remember that. It has now been explored as research for other symptoms of Parkinson's as well. The tremor not only, but rigidity, the stiffness, and the slowness. Basically all Parkinson motor features. Just like we do DBS for all these features, not just for tremor. But that's not FDA approved yet, and it's a different area in the brain that is currently being investigated. So for now, I can only offer you, and even not now, but next year, we can look at bad tremor and make it a lot better with the focused ultrasound. But the other treatments for other symptoms will be later down the, what is that? Down the
road.
Down the pike, the road. Good. All right.
I have a question about the synuclein antibodies that I spoke of. And the question is, what stage is this study? How advanced is this study? When we talk about stages of study, we use numbers. A stage 1 study means we're looking at its safety in patients with people without the disease, just safety in the human body. Stage 2 is looking at safety and getting a little bit of information on the positive effects in the target population, in our case, Parkinson's disease. And stage 3 is the large clinical trial, usually hundreds of patients, in order to demonstrate, is this better than placebo? The antibody studies are stage 2, all right? They are target population in patients with Parkinson's disease, but at this point, we're looking at safety. Is this safe? Is it tolerated? And that's why we don't give the injection as a vaccine and say, good luck. No, because that's, you can't undo. We give the infusion every month, and we watch these patients to make sure that they're reacting well, that they're not having any problem. And this will be a long term. After we have enough safety data, then we can go back to the FDA and say, we think we're ready for the stage 3, if in our phase 3, in fact, if we are. So that's how that is in terms of where we stand with the synuclein. Very active, but still looking at safety.
I'm going to interrupt real quickly. There's one car remaining in valet with a gray Mazda. If that owner would like to go down and grab their keys real quick, the valet will be able to leave it in front of the building. So if there's an owner of a gray Mazda who is in valet, if you want to run down real quick.
Okay, and in the interest of time, we'll do one more question, and then the remainder of the questions will be in our newsletter. We'll have the questions and answers there. So,
one more.
Well, I have one on side effects of medicines. If the inhalation levodopa helps to get you to the next dose, will it induce dyskinesia? Well, it might, yes. I mean, that's what we would be testing. We're giving more levodopa, and you don't get anything for free. We know that. So, yes, we would have to be cautious about it. That's why in most cases I start with a half dose. A dose is 2 capsules. I instruct my patients to start with just 1 capsule, and let's see how it goes. Another side effect of amantadine. Amantadine is cleared by the kidney, so you must have good kidney function, and you must drink a lot of water if you're going to be on amantadine. Side effects include ankle swelling, an unusual rash that's kind of purple and net-like. It's called livido reticularis. That is not dangerous, but it can be unsightly, especially for women who wear skirts during the summer. Men who wear long trousers during the summer would not be bothered by it. But there are some men with shorts on here, so they would also. And finally, a little bit of mental confusion can occur with amantadine, especially if the dose is not kept low or if the kidney function is not completely normal. I want to thank everybody for attending. Let me turn this back to our chair.
Okay. Thank you so much for spending your Saturday with us. I again want to thank our wonderful staff and all of our faculty without whom this could not have been done. And we look forward to receiving your feedback with your forms, so please turn that in to us. And the remaining questions will be answered in the newsletter, and we'll hopefully see you next year. Thank you.